We'll come to order. Mr. Secretary, welcome our former colleague. Welcome here today. The chair will recognize himself for an opening statement. Today, we're here to discuss the fiscal year 2024 budget for the U.S. Department of Health and Human Services. First, I want to say I have great concerns about the budget. After driving up inflation and federal spending, the President put forth the largest budget request in our nation's history of almost $7 trillion. In the HHS budget specifically, the Centers for Disease Control and Prevention gets a significant increase in funding. And the question we have to ask is, why should taxpayers give higher levels of funding to CDC when public trust has been eroded in the CDC due to politicized responses to the COVID-19 pandemic? The CDC, and we all need to work together to give serious reforms to restore the public trust and need to get back to its core mission. The HHS budget also has unfunded mandates on state Medicaid programs. The President also touts his budget increases Medicare solvency for another 25 years. This will be done through increases in taxes on American households and more price controls to forcibly set prices for pharmaceutical drugs. These efforts will ultimately backfire and lead to even fewer life-saving cures for our seniors. On fentanyl, the President recently stated, and I quote, MAGA House Republicans' proposals would slash funding for border security, a move that could allow nearly 900 pounds of fentanyl into our country, end quote. Clearly, the President has failed to check the Customs and Border Patrol's website before releasing his budget proposal. Under the President's watch, Customs and Border Patrol has seized over 11,000 pounds of illicit fentanyl at our southwest border. That's just in the first 6 months of this fiscal year and represents nearly the total amount seized in all of fiscal year 2022. These are just fentanyl seizures, not what is actually being trafficked without being seized by the Customs and Border Patrol. At the same time, drug overdoses eclipsed 107,000 in 2021, the highest ever in the United States. More than 70,000 of these deaths were from synthetic opioids, such as fentanyl. The President's budget uses the word fentanyl twice compared to in the HHS budget, compared to 42 times it mentions climate change. This is unfair to the thousands of families across the country who have lost loved ones to fentanyl poisoning. I call on the administration to join us in supporting a class-wide ban on fentanyl-related substances. The Fault Fentanyl Act would do this, and it was passed out of this committee less than a week ago with bipartisan support. It is long past time we permanently schedule all fentanyl-related substances in Schedule 1. The administration also talks about working on health equity. Well, however, the Centers for Medicare and Medicaid Services recently declined to cover an entire class of FDA-approved Alzheimer's treatments for Medicare patients. This significantly reduced access to care for minority and rural patient populations with no other options to treat this treacherous disease. The Biden administration has also proposed cutting health care benefits for millions of Americans who receive health insurance through ACA exchanges. And most recently, the Biden administration proposed slashing Medicare payments for drugs approved through the accelerated approval pathway, which have significantly improved access to care for cancer patients over the past decade. I was hoping that this budget might offer a focus on policies where we can work together. This committee held a bipartisan, very informative hearing yesterday on healthcare affordability and and transparency, in highlighting the ways we can improve and empower patients through greater price transparency. This budget fails to mention price transparency. It's a real missed opportunity. Consider all the bipartisan support for greater transparency across the healthcare system. I invite the Secretary to work on all of us on this committee on this issue. And in closing, I thank you for being here. I thank you for being here today. I know that we may disagree on some of the things that we're talking about today, but we do agree that we want people to have access to better health care. And to that end, I believe we can work together on these pressing issues in a bipartisan fashion, and I hope that we can work together. And I will yield back. The chair now recognizes the ranking member of the subcommittee, Ms. Eshoo of California, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Good morning, Secretary Becerra. Welcome back to the Health Subcommittee. You are always welcome here. My thanks to you, to the Biden administration for your work over the past year to improve our nation's healthcare system. Premiums under the Affordable Care Act are at an all-time low, and enrollment is at an all-time high. So I say bravo. A record-breaking 16.3 million Americans signed up for health coverage under the ACA, including more than 3.6 million Americans who are newly insured, and 4 out of 5 enrollees qualify for plans that cost $10 or less a month. These are stunning figures. And while there may not be applause on one side of the aisle here, I think there's applause across the country with the American people. We're very proud of that. We've also made progress on fighting the fentanyl overdose crisis. The number of providers able to prescribe buprenorphine for opioid use disorder has increased by 19%, and naloxone prescriptions filled in pharmacies has increased by 37% in the past year alone. For 6 months in a row, there's been a steady decrease or flattening in overdose deaths. No one can be satisfied with whatever the number is, but that the number is decreasing is an improvement. Why? Because access to treatment saves lives. President Biden's fiscal 24 budget request builds on these achievements and addresses the remaining gaps in our healthcare system. To continue lowering costs, the budget proposes making permanent the enhanced premium tax credits that were extended to 2025 in the Inflation Reduction Act, expands surprise billing protections to ground ambulances, and caps the monthly cost of insulin at $35 for Americans with group and individual market coverage. We get that through, everyone in the country, whether they're young, middle-aged, or Medicare beneficiaries, will enjoy that critical benefit of capping insulin at $35 a month. Importantly, the budget provides a historic $46.1 billion to address the overdose crisis. This funding will go toward efforts to get people the evidence-based care they need, reduce the supply of illicit drugs like fentanyl, and go after drug traffickers to stop overdose deaths. The president's budget outlines a strategy to use over $13.8 billion to improve our nation's mental health, including increasing the availability of crisis care and achieving full parity, which we have struggled with, between physical and mental care coverage. The budget also invests $50.5 billion in pandemic preparedness, including $20 billion in mandatory funding to prevent and address current and emerging public health threats. Finally, President Biden has proposed increasing the Medicare tax rate to 5% for those making over $400,000 a year and closing loopholes. These reforms will make the Medicare Trust Fund solvent beyond 2050 to ensure older Americans can really retire with dignity and security. Instead of looking toward the future, what I hear the House Republican leadership reportedly want to cut 2024 discretionary spending back to the 22 level. These cuts would decrease access to the essential government functions each of our constituents rely on. So I look forward to hearing from you. We all do, Mr. Secretary, both on the impact of these cuts and working with you and your team to build on the progress of the last 2 years to improve our nation's health and our overall well-being. When people are healthy, we have a stronger nation. So we have a responsibility to keep investing in that. So thank you for what will be, I'm sure, your instructive testimony, and I yield back, Mr. Chairman.
Thank you. The gentlelady yields back. Chair now recognizes the chair of the full committee, Chair Rogers, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Today's hearing on the President's budget for the Department of Health and Human Services comes at a time when we need to return hope and optimism to America again, so people can live fuller, happier, and healthier lives. We need to come together to stop the fentanyl crisis and save lives. We need to rein out-of-control government spending to reverse President Biden's inflation crisis so people can afford health care. We need to help build and support strong communities so people are less lonely, less anxious, and restore a sense of purpose and belonging for our children. There must be accountability from the administration, too, for too many ways that they have made the crises worse, especially the authoritarian COVID-19 policies. Secretary Becerra, the President's budget should reflect the solutions we need to make people's lives better. Unfortunately, that's not what we're seeing. Regarding fentanyl, as Mr. Guthrie said, the President's budget only mentions this twice. It's unacceptable given more people are dying from fentanyl poisoning in America, the #1 killer of 18 to 45-year-olds. This committee has heard from several parents, such as Molly Kane, who emphasize their children are not suffering from a substance use disorder, but that their teenager purchased a pill off of Snapchat or bought cocaine not knowing it was laced with fentanyl and died. Your budget request for increased funding for medication-assisted treatment, while important, doesn't seem like it would have prevented these individuals from dying from fentanyl poisoning. This is perhaps the greatest threat facing our communities. But your budget doesn't reflect all aspects of the terrifying reality of this crisis. Regarding healthcare cost, this committee came together just yesterday in a bipartisan way to explore ways to lower healthcare costs with more price transparency and more competition. This is a top priority for those we serve. Yet your budget says nothing regarding bipartisan efforts to implement and enforce the transparency efforts brought forth during the Trump administration. In addition to lowering cost, this administration needs to take restoring trust in public health agencies more seriously. The buck stops with you. You oversee our public health and preparedness policies under CDC and NIH. As I've said, these agencies need to do the hard work of restoring trust with the American people and comply with our oversight before they ask for more money and more authority. The NIH, in many cases, has failed to be a steward of the American taxpayer dollars or ensure lab safety. It has stonewalled this committee's request for information that we are constitutionally entitled to, and it refuses to completely answer questions about what sort of risky gain-of-function research it may fund or what role the National Science Advisory Board for Biosecurity is playing to keep Americans safe. Similarly, the CDC has created a crisis of confidence, so much so that the CDC Director Walensky has undertaken a full-scale reevaluation and reorganization of the agency. This is because its guidance was used to justify mandates that have more parents now questioning routine vaccination. Its guidance, influenced by teachers' unions, kept schools closed to justify mask mandates on kids. We know these weren't decisions based upon the best science and data. Now our children are paying the price, academically, physically, emotionally. Like NIH, the CDC does not need more authority. It needs robust oversight. Secretary Becerra, let me be clear. We expect better. The American people are eager for a brighter future. We expect a high degree of cooperation from you on policies that will help improve their health and their quality of life. And I hope that you leave today with a greater sense of the urgency that I feel and every member of this committee feels to address these problems. And do it in a bipartisan fashion. We are committed to bringing the Republicans and Democrats together to address fentanyl, together to address the need for public health, trust in our public health agencies like CDC and NIH, and together, as we did yesterday, on price transparency that would really help restore the doctor-patient relationship and bring down the cost of health care. That's our goal. We're committed to doing it together, and we thank you for being here today, and there's more to come. Thank you.
Thank you. The gentlelady yields back. The chair now recognizes the ranking member of the full committee, the gentleman from New Jersey, Rep. Lom, for 5 minutes.
Thank you, Chairman Guthrie. I want to thank Secretary Becerra for being with us today to discuss the President's Fiscal Year 24 budget request for Department of Health and Human Services. But I have to start out by saying I hear my GOP colleagues criticize the President's budget, but they don't have one. They don't have one. There's every reason to believe that we're never going to see one from them. And, you know, they criticize the fact that they talk about Alzheimer's research, fentanyl, price transparency. Well, why don't you go to the House Republican leadership and say that they should put a budget together that has more money for Alzheimer's research or more money for fentanyl enforcement or price transparency? I mean, I have to say, I don't really think you should be criticizing something without an alternative, and there isn't one, and there's a lot of reason to believe there isn't going to be one. So thank you for being here and defending something that exists. And if the criticism is that they don't like something that's in it, then I know you're not going to do that, but I'm going to say, well, then let us see what you have as an alternative, Republicans, which we're not seeing. Let me just say, I don't want to repeat all the great things that the Biden administration and congressional Democrats delivered for the people in the last year. But I'm going to say a few things. Thanks to the Inflation Reduction Act, we finally allowed Medicare to negotiate prescription drug prices. We have the Medicare, the cap on insulin. We built on the ACA. We have now 16.5 million Americans who signed up for coverage through the ACA marketplaces. Expanded subsidies are driving costs down. An average family is saving $2,400 a year in premiums. The President's budget also increases the number of drugs Medicare selects for negotiation, extends the $35 monthly cap for insulin to people with private insurance, and makes permanent the ACA enhanced premium subsidies. So this administration is addressing the affordability issue, which is so crucial to Americans. The Biden budget also proposes to finally ensure that all low-income individuals have access to the benefits and protections of Medicaid, regardless of the political decisions made by their governors and legislatures. North Carolina just became the latest state to recognize that Medicaid expansion is not only morally necessary, but also a sound economic decision. And I'm also pleased to see that the budget would expand access to home and community-based services, because if people stay at home and out of hospitals and out of nursing homes, we save money. The budget would also require all states to provide Medicaid coverage to all low-income women for 12 months postpartum. We have a maternal mortality crisis. We need to do that. There's a lot of progress in other areas, such as enhancing public health programs. I'm encouraged to see that the budget prioritizes funding for important public health and workforce programs. It invests in pandemic preparedness and biodefense to ensure that we're prepared for future challenges. Now, the Biden administration lays all this out, but I don't know what the other side's doing because they have no budget. But there is a leading Republican proposal that would cut trillions of dollars from Medicaid, including repealing Medicaid expansion, would rip away health insurance from 17 million people by doing that. And these proposed Medicaid cuts are going to hurt everybody. The Republicans have also talked about eliminating the ACA expanded tax credits and subsidies, and more people would then be uninsured. Now, let me explain. The burden on the healthcare system when states don't expand Medicaid or when the federal government ACA subsidies are cut is severe. Red states that have not expanded Medicaid are seeing their hospitals starve for funding because of the number of patients receiving uncompensated care. Medicaid isn't just important to cities, it's important to hospitals and nursing homes or community health centers in rural areas, in Republican districts. So all these things that we're hearing, we don't really know if they're, what they're doing because there's no budget, but all the things that we're hearing are going to hurt that they want to cut. Medicaid in particular, ACA, these are going to starve the healthcare system. And I know that, on the one hand, we hear the Republicans say, we have to reduce spending. But then on the other hand, they talk about more spending for other things. So unless I actually see something, as what the administration has proposed, that really reduces the deficit and expands coverage and make things more affordable, I have no reason that a Republican proposal would accomplish any of those things. And I fear, from what I hear, that in fact it does the opposite, if we ever even see it. So thank you again for being here, and I yield back, Mr. Chairman.
The gentleman yields back. The chair reminds members that pursuant to committee rules, all members' opening statements will be made part of the record. Are there further opening statements? The chair recognizes Dr. Burgess for 3 minutes for an opening statement.
And thank you, Mr. Chairman and Mr. Secretary. Thank you for being here this morning. Several times since the beginning of this year, I've reached out to your office hoping that we could get a chance to talk about more than the things I can discuss in the 5-minute question period. Unfortunately, I've not been able to secure such a meeting. The comment from your office is you're unavailable for the foreseeable future. I hope that we can, in fact, get together at some point and talk about a number of these things because they are absolutely critical. One of the things that has come up over and over again in my world is what is happening to, it's one thing to have coverage, but if you've got no one to deliver the care, it becomes extremely problematic. So some of the things that are happening to our providers, to our doctors, based on reimbursement is really going to set us up for big-time failure down the road, regardless of the state of coverage. So price-setting provisions in the Inflation Reduction Act, physicians are going to see a reimbursement cut as the maximum fair price replaces the average sales price in Part B. Part B administered medicines, primarily affecting oncologists, neurologists, rheumatologists, infused drugs that are given in a doctor's office. Those reimbursement rates are going to be significantly cut under the maximum fair price. No one really knows what that is. It's actually set by you, which is another reason I would very much like to have a conversation about it. But at a time when the country's facing physician shortages, policies that result in physicians being reimbursed less for the care they're already given, that's not going to lead to appropriate physician interaction. I don't know that this administration realizes the circumstances that doctors are facing every day. It's not just that they've seen reimbursement cuts year over year over year. It's now that they've got 6, 8, 9% inflation to deal with. They still have to pay their office staffs. They still have to pay the rent. Their electricity bills are going up. The cost of living for them is going up, and they simply cannot afford to stay in practice. So what happens is doctors will say, I cannot afford to see a Medicare patient. That's a tragedy. And then, of course, some doctors are simply saying, this has become too difficult. The government has made the practice of medicine too hard, and I am going to stop. And that is a real tragedy. We're in a position in this country where we cannot afford to lose additional providers. So, again, the policies of the administration, policies of your agency are actually adding to this. So at the end of the day, I hope that you will continue to engage with the physician community on this. I hope you and I will be able to have further conversations on this. And beyond that, I look forward to today's conversation. Thank you, Mr. Chairman. I'll yield back.
The gentleman yields back. Anybody on the Democratic side? The chair recognizes Mr. Cardenas from California for 3 minutes.
I'm glad we have the opportunity to discuss these important issues on this committee today. And I want to thank you, Chairman, and the ranking member as well of the subcommittee. And I also want to welcome the opportunity for us to have a nice, honest, robust discussion with Secretary Becerra. And I just look forward for us to getting to the real issues. It sounds like some people think that we're going to solve all the world's problems in this hearing, and that's not going to happen. But we are going to cover some good ground, and hopefully we can have some robust, honest discussions. To me, I'll yield to Dr. Ruiz.
Yeah, I appreciate the moment. The pandemic was mentioned, and I think it's important to highlight the differences that occurred during the Trump administration, the Biden administration. We definitely need to have a comprehensive approach to examining actions taken in the earliest days of the public health crisis. From the beginning, President Trump and his administration did not act with the urgency needed to reduce transmission, communicate honestly with the American people, and equip our schools with the resources they needed. Instead of working to efficiently manufacture PPE, scale up testing, promote basic public health measures like masking and social distancing, President Trump chose to politicize this virus, calling it a hoax and downplaying its severity, saying it would go away like the flu. But as the coronavirus reached pandemic proportion, public officials of all political persuasions had to act to suspend in-person learning and social distancing and promoting the mask wearing. And so President Biden took a different approach, swift action to develop evidence-based guidance for schools and works and throughout our society and all hands on deck, and to get schools back safely and responsibly. And the results speak for themselves. For example, in schools alone, 1 year after President Biden was sworn into office, our efforts more than doubled the number of schools open for full-time in-person learning to 95%. And schools didn't just reopen, they stayed open. Today, more than 99% of schools in the United States have safely and responsibly reopened for in-person learning. This is a direct result of the American Rescue Plan's targeted investments in childhood education to keep students healthy and safe while they learn. In fact, key funding from the American Rescue Plan is already at work. Since schools were mentioned, rebuilding schools, crumbling infrastructure, upgrading their ventilation systems, and getting students the resources they need. And so this is a key component that I know that the all-hands-on-deck government response by President Biden, and oftentimes led by Secretary Xavier Becerra, with the equity focus to make sure that the hardest hit, the hardest to reach communities were front and center to do the outreach necessary to save lives, reduce transmission, was a key component of why we are back to where we are now. And so with that, I applaud the administration. There's a lot of work to do. There's a lot of the pandemic experience weighs heavy on a lot of people's experiences, and we need to help our children now with solutions. And with that, I yield back my time.
Yield back. Thank you,
The
Mr.
gentleman yields back. Any other opening statements on the Republican side? Any further on the Democrat side? Seeing none, our witness today is the Honorable Xavier Becerra, Secretary of Health and Department of Health and Human Services. Appreciate you being here. I know you understand the lighting system, so I want to explain that. We will now recognize you 5 minutes for your opening statement.
Chairman Guthrie, Ranking Member Eshoo, to Chairwoman Rogers, and to Ranking Member Pallone, and to all the members of this committee, thank you for the invitation. A lot has happened in a year since I last spoke to you about budgets. More than 16 million Americans have secured, and Congresswoman Eshoo, 16.4 million. We added that 0.4 instead of 0.3. 16.4 million Americans have secured health insurance through the Affordable Care marketplaces. That is, as you've heard, an all-time high. Altogether, more than 300 million Americans today now carry insurance to cover their health care. That, too, is a historic high. The President's new lower-cost prescription drug law has capped insulin at $35 per month and made preventative vaccines like the flu, COVID, shingles, which I hear about a lot, available for free under Medicare. Moving forward, this new law gives us the right to finally negotiate lower prescription drug prices for Americans. To cap it off, the Biden-Harris administration has safely and effectively executed the largest adult vaccination program in U.S. history, achieving nearly 700 million shots in arms during the COVID pandemic without charge. The FY 2024 budget proposes $144 billion in discretionary funding and $1.7 trillion in mandatory funding for HHS. It positions us to tackle the urgent challenges we face, including a growing behavioral health crisis and future public health threats. It also funds operations and mission-critical infrastructure needed to build a healthier America, moving the nation from an illness care system to a wellness care system. An illness care system leaves our most vulnerable families behind. A wellness care system invests in providing the full spectrum of health care to all Americans. Illness care allows the price of prescription drugs to skyrocket. Wellness care starts by prescribing fruits, vegetables, and exercise. It treats food as medicine. Illness care requires you to get a referral by your family physician to see a specialist for mental health services. Wellness care, well, it lets you get mental health care the minute you walk through the door of your family physician's office. Illness care forces hardworking Americans to deplete their life savings in order to get long-term care that they need. Wellness care invests early in long-term care, like in-home care, so our older adults and Americans with disabilities can thrive at home in their communities. Our budget, the President's budget, invests in wellness care. It includes funding for health centers, the National Health Service Corps, teaching health centers, and other areas that provide critical support to Americans, and it should continue without interruption. We also invest more than $30 billion to prepare us for the next COVID or public health crisis, including $1 billion to replenish our nation's strategic national stockpile. On behavioral health, too many of our loved ones are dying from suicide or overdose. So we increase access to crisis care. We grow the behavioral health workforce, and we beef up substance use services. We're also gearing up to handle more than 6 million additional contacts from people who are experiencing a mental health crisis. We do that through 988, the 3-digit suicide prevention lifeline we stood up last year. This budget covers 2 million adults left out of Medicaid by their home states and extends tax credits that make health care more affordable for millions of Americans. It would also ensure that expanded postpartum Medicaid coverage for a new mom and her baby is here to stay. The President's budget not only strengthens Medicare for our today's seniors, but protects and strengthens it for the next generation. We also take care of our family members in this budget. By investing $600 billion in child care and preschool programs and $150 billion to strengthen Medicaid home and community-based services. This budget funds Cancer Moonshot and ARPA-H. It invests in Title X family planning programs, so essential to so many of our families, and it delivers on commitments made as part of the National Strategy for Hunger, Nutrition, and Health. And important to me as a former Attorney General, it bolsters our healthcare fraud and abuse detection and enforcement work. Finally, the President's budget honors our responsibilities to Indian country with more than $2 billion in new resources in 2024. This budget reflects the President's values, it reflects our values and commitments, it helps begin the move from a nation focused on illness care to one about wellness care, and most importantly, it ensures health and wellness are within reach for all Americans. On behalf of the women and men of HHS, we look forward to working with you, and with that, Mr. Chairman, I yield back.
Thank you. The gentleman yields back. We will now move to questions, and before we get started, to respect the Secretary's time, I think at 1 o'clock you have a hard stop, and to respect our members, everybody have the opportunity to ask a question. At 5 minutes, I'm going to gavel, so everybody understand, don't ask your question with 3 seconds left because we're going to respect everybody's time to move forward. So having said that, we'll get started now, and I will recognize myself for 5 minutes. So, Mr. Secretary, last year when you were here, we talked about scheduling fentanyl, and you said, and I quote, I wouldn't ask you if you were for permanently scheduling fentanyl analogs, and you said I wouldn't get ahead of the agencies that actually do the science. So the Drug Enforcement Agency has testified before this committee when we had our hearing, and they said their number one priority this session is scheduling of illicit fentanyl, making it permanent scheduling, their number one legislative priority. Do you agree with the DEA that we should finally permanently schedule fentanyl-related substances as Schedule I drugs?
The FDA has spoken on this, and yes, we do want to see it scheduled. We don't want to have to continue to see Congress reauthorize this, and so we hope that we'll be able to work with you on that.
And
there are other things.
Subject to mandatory minimums?
No, well, that's where we can have that conversation because we are interested in discussing a comprehensive approach on how we deal with fentanyl and drug overdose.
We want to as well, but I just don't understand why somebody selling a derivative of fentanyl should be treated less than somebody selling fentanyl. I can't understand that.
We can
I can't
discuss,
understand. So go ahead.
Yeah, and the Department of Justice would be more than willing, I think, to discuss some of these issues about mandatory sentencing, mandatory minimums. What I can tell you is from HHS perspective, what we need to do is make sure we're helping do the research that will help us find the cures, the treatments that are necessary. You've probably heard the news today that the FDA has now announced that Narcan will now be provided over the counter, so any consumer can go in and purchase it. That will save lives. So we're doing the things that will help keep people alive, and we look forward to working with you on a comprehensive approach.
Well, thanks. I want to move to the IRA. We had H.R. 19, which it wasn't bipartisan, I won't say, but every provision in it had a bipartisan solution in it because we all want lower drug prices. We had a hearing yesterday on healthcare costs. We want to deal with it. But when the IRA passed last year, one of our main concerns was the innovation, and CBO said that it would lead to 15 fewer cures over the next 30 years, in a modest estimate compared to others, but the official CBO score. And we've already seen examples, I think, of a couple of, in 4 months already, drugs in phase 1 and phase 3, I believe, a rare eye disease, and also a cancer drug having the R&D cut. And so our concern, do you believe that, so my question is, do you believe that CMS should consider the divestment in certain therapies that could eventually lead to the development of cheaper alternatives as the agency makes decisions on setting the price of certain therapies.
And CMS will be having further conversations with the Hill on exactly how we're going to move forward on the price negotiation. What I think you're going to find is that they're going to try to move towards a more competitive system that allows us to get the best price for those drugs, but not let drug companies gouge the American consumer. There's no reason why we should continue to see Americans paying 2 to 3 times more for drugs here in America when those same drugs are sold in other parts of the world for so much less.
We agree. That's why we want to expose the price that people pay, the price it takes to make it, the price that goes through the system. So we agree on that. But we're concerned about, and we've already heard that there are big pharmaceutical companies, and people point out they've made billions of dollars over the last couple of years, and we're not here defending that. What I'm saying, though, most innovation comes from small business. A lot of them from Stanford, I know you're in California, small people who start businesses, they're researchers, and they start their own businesses, and they really need venture capital to move forward. I'm not talking about a handful of pharmaceutical companies that really come up with our moving forward, and so they've already talked to us and said the venture capital is concerned about the 13-year and 9-year, the 9 small molecule and the other. And now you're talking about going to 5 and expanding more drugs. So when you were talking about that in your discussion in making this proposal, did the idea of lack of innovation, we had a hearing on it last year, and we've had people on this committee say, we're willing to trade some innovation for cheaper prices. Did y'all discuss the lack of innovation when you had these hearings?
Mr. Chairman, without a doubt, everyone has discussed innovation. Everyone wants to make sure that we have a competitive industry. Everyone wants to make sure that we have a domestic production of the best drugs that the world can produce. And so all of that is part of this process. The legislation that passed actually provides a safe harbor for a lot of those innovative companies so they can continue forward. It makes sure that we don't take on every particular prescription drug for price negotiation right away. And what we're going to try to do is make sure that not only do we stimulate more innovation and more production, but we do it in a way that keeps the price fair so that there is still a profit for the company producing the drug. They deserve to earn a profit. But gouging is not acceptable. And I think you and I would agree that there's gouging going on. And that was the purpose of this new prescription drug law, to lower the price of those prescription drugs that we know. There is no reason why we could have had insulin for $35 a month 10 years ago, 20 years ago.
We just have to expose the price. You're right, as we want to do. So I'm calling myself down, I guess, on that. I yield back to myself, and my time has expired. I recognize the gentlelady from California for 5 minutes.
Thank you, Mr. Chairman, and not to mention the games that are played with patents by the drug industry. I just have to throw that in there. It's great to see you here, Mr. Secretary. Yesterday, our subcommittee held an important bipartisan hearing on transparency in healthcare. It's been mentioned. Our expert witnesses testified on the importance of shedding a light on fraud, on waste, on abuse that really poisons the healthcare industry and hurts patients. So based on their remarks, I think that I assume that all of my colleagues should be able to support your agency's actions to audit Medicare Advantage plans to recover overpayments. Now, I remember years and years and years ago at this committee on the issue of waste and fraud, that there were individuals whose cases had been adjudicated. They were on their way to prison. This was the private sector ripping off the public sector in Medicare. It was billions and billions of dollars. And they testified as to how they did that. It was so highly instructive. Obviously, I still recall it very well today. So you mentioned in your testimony that you're doing audits to save taxpayer dollars. There are ads on TV saying that President Biden is cutting payments to Medicare. Can you set the record straight on this and how much you estimate those audits are going to cost? I know it's something in there's money in your budget for that.
Congresswoman, thank you for the question. The reason we are doing the audits is because now we have collected enough data to actually show us how some of the money that we provide, taxpayer money, in Medicare is being spent. And what we're finding is that there is a lot of overbilling. And we're trying to recoup that money because when we recoup it, we put more money into the Medicare program to put back into the services and benefits that Medicare beneficiaries will receive. The program will cost us a fraction of the billions of dollars that we will recoup in these audits. And so we're hoping to move forward. But the difficulty we have is that there are millions being spent today, tens of millions of dollars are being spent today on these commercials, deceptively speaking to Medicare beneficiaries, scaring them, quite honestly, because there are billions at stake. And that's a pretty wise investment if you think about it. They're trying to save billions of dollars in returning money to the Medicare program, and it's only going to cost them some millions of dollars in commercials.
Yeah, so in other words, let's be for fraud and abuse because it's my plan. Hell of a line.
We're going to continue forward. And
Good.
We have to.
I'm with you 1,000% on that. It's been reported that the House Republican leadership plans to cap fiscal year 24 discretionary spending. What I'd like to know is how many fewer grants would that mean that NIH would be able to support?
Congresswoman, we estimate that if some of these proposed cuts, and again, we've not seen the budget, but what we've heard are some of the proposed cuts, NIH probably would face a cut of about, billions that would cost us about 5,000 grants that are done by NIH researchers.
5,000 NIH
5,000.
grants. Would that include a funding for Alzheimer's, for instance?
Could include Alzheimer's, cures for different diseases. The research that's being done by NIH is to fund and find cures for diseases. So some 5,000 grants would probably have to be rescinded or not put out.
You know, this debate about how much money, and it's a worthy debate. It's a very important one. I would link the dollars to keep building on the progress that the United States of America continues to make. And when you pull back, it pulls back on the progress. So this is not just an accounting exercise. This is about our collective society and what kind of, what the progress is and what we need to invest in. Bravo on ARPA-H. I'm thrilled. That was a bipartisan effort here, and I'm glad they're up and running and doing business. Thank you.
Gentlelady's time's expired. The chair now recognizes Dr. Burgess from Texas for 5 minutes for questions.
Thank you, Mr. Chairman. Again, Mr. Secretary, welcome. Good morning. Yes, ARPA-H, important. I hope you'll look favorably on the state of Texas to locate it at an area that has already proven an ability to provide what you're looking for with some of the work the state has done on cancer prevention and research. So you've had a busy week and you've been into a fair number of committees, both on this side of the hill and the other side of the hill. There seems to be a narrative emerging that HHS is attempting to convince Congress that there's been a much higher volume of claims under the No Surprises Act, a higher volume of claims submitted for independent dispute resolution than anyone could have predicted. So your responses to Dr. Harris of Maryland, Senator Bennett from Colorado, and Dr. Wenstrup of Ohio, and you cited the sheer volume of claims and asserted that some were frivolous, implying that providers are not acting in good faith. Now, I have providers calling me literally every day and stating that they are winning much more often than they lose during the arbitration process. Their win rate is over 75%. Unfortunately, because of the HHS backlog, only 3% of the submissions have made it through the process. So what's the deal here? Are the claims that are being submitted really not actually necessary? And it's hard to square that with the fact that so many are decided in favor of the intervener.
And Congressman, thank you for asking the question, because I'm going to connect the final dots to what you just said. Those physicians who are having success are, as you said, they're going to start to see a slowdown in the adjudication of those claims. The reason they're going to see a slowdown is because neither you nor I or anyone who actually had the wisdom to propose and enact the No Surprises Act believed that we were going to have the volume of submissions of claims. I guarantee you, you did not believe that in the first 8 months we would have 164,000 claims submitted.
Let me, if I could just reclaim my time. First off, I want to point out I voted against the No Surprises Act because I was worried about this exact thing. But when Texas, as you know, had their own version of the No Surprises Act that was passed in the state of Texas, the first year they saw 45,000 claims in the first year. In the first 6 months of 2021, the very 6 months where you all were beginning to implement the No Surprises Act at the agency, they had another 50,000 claims. And Mr. Chairman, I'm going to ask that the Texas Senate bill evaluation from Texas Department of Insurance be inserted for the record. But your department estimated, so that's 100,000 claims basically in the first year, and your department estimated the annual number of submissions would be 17,000 nationwide for the whole year. Did you not look at the data that had already been accumulated in a single state that had implemented a similar law in the year and a half before you're started? I mean, I can only draw the conclusion that you didn't look at the data that was available, and then to turn around and blame providers for your department not being prepared for the volume of claims, it just doesn't square with me. And from everything I've heard so far this week, I believe that to the extent of this process is a failure, and it's a failure because of poor planning on the part of HHS and mismanagement of the law passed by Congress. So instead of blaming providers for the department's mistakes, I hope going forward we can focus on resolving the backlog. When 75% are decided in favor of the person who brought the claim, but 3% are getting through, we got a real problem. And again, it comes back to keeping doctors involved. Let me just shift gears and ask you a question because it came up in other testimony. You stated you were unfamiliar with statistics reported by the New York Times that HHS has been able to contact over 85,000 unaccompanied alien children who've been released from HHS custody. Are you now familiar with that 85,000 figure, and are you aware of from where it comes?
Congressman, I'm aware of where it comes. It's not a statistic. It is a number that New York Times came up with.
But the fact remains, there are children that you cannot identify where they are that have gone through your system, and it seems to be the throughput is the critical thing, not the child. And that's bothersome to a lot of us on this committee.
No, see, there's a misunderstanding about what we're supposed to do and what we are then able to do once a child is placed. If you take a look at the law that was passed by Congress, Congress gave HHS the responsibility, the authority to provide the custody and care of a unaccompanied migrant child.
I know you want to answer. We're out of time. I need to move on.
I'll look
Just
forward
want
to
to
your
clarify
answer.
the misunderstanding. Maybe I'll have a chance later on.
Absolutely.
I'll submit that to you in writing because it is important. Thank you, Mr.
Mr.
Chairman.
Sarbanes, you're recognized for 5 minutes for questions.
Thanks very much, Mr. Chairman. Secretary Becerra, welcome. As you know, a strong, well-trained workforce is critical to ensuring a high-quality healthcare delivery system that can deliver all the necessary care for all patients today and be prepared for future public health crises. While nearly every industry is facing workforce challenges across the country, I want to focus today on how President Biden's budget addresses those faced by the healthcare workforce. According to HRSA's most recent workforce estimates, current demand for healthcare providers, especially primary care physicians and mental and behavioral health providers, far outpaces supply. And without meaningful action to turn the tide, this gap is only projected to widen over the next decade. We've already seen how shortages at every level can impact access to care for individuals. In Maryland, for example, we are facing long emergency room wait times and a mental and behavioral health care crisis that is particularly acute for pediatric patients. While these are complex problems that require comprehensive solutions, a key part of those solutions is addressing shortages in primary, mental health, and skilled nursing care so that every patient can access the level of care they need at the time they need it most. The President's budget certainly reflects an understanding of the importance of these investments in the healthcare workforce and would provide robust funding for programs that have a proven track record of strengthening our healthcare provider pipeline and delivery system. For example, the budget includes, as you know, $2.7 billion for HRSA's workforce programs, including a $548 million increase in funding for the National Health Services Corps, additional resources for graduate medical education and other training programs, and $28 million for a new program to address healthcare workforce shortages. Mr. Secretary, can you speak a bit more about these investments, particularly in the new program to address workforce challenges, and how they will work together to build a stronger provider base that can meet the needs of every community?
Congressman, thank you for the question, and thank you for championing the ability for Americans to stay in the healthcare workforce and to increase the numbers. We are doing what we can in the budget to actually support an increase in our workforce, whether it's the healthcare workforce or, as you'll see in the President's budget, for the child care workforce, because we know that the needs are dire. What we also are trying to do is figure out how to best direct the next generation of healthcare workers. So our National Center for Healthcare Workforce Analysis is trying to collect some of that information, the data that will tell us where the shortages are, not just geographically, but by profession. And so we're going to do everything we can to give states the best guidance, because they're the ones that ultimately certify and license individuals, and we want them to know where their needs will be coming into the future.
Thanks very much, and I appreciate you talking about the data, the importance of collecting information on where the shortages are. That can inform recommendations about a national policy to address shortages within the healthcare workforce. Congressman Blunt Rochester and I, again, have led a letter this year to the House Appropriations Committee requesting $11 million for the National Center on Health Workforce Analysis that you mentioned for FY 2024. And as you know, that center releases a lot of really critical information about the supply and demand challenges, and increasing its funding is, I think, very critical to help this committee, to help your department and agency make the smartest decisions we can possibly make when it comes to investing in our healthcare workforce. Building upon the American Rescue Plan and the Inflation Reduction Act's historic reforms to lower healthcare costs for Americans, we've got to look at this workforce shortage. Let me freestyle a little bit with you here right now, a bit more on this. Do you think we could put together a kind of broad national health workforce strategy that brings various partners together who may not have collaborated previously? For example, we look in Maryland at these shortages around nursing. We know that we even are lacking instructors for nursing programs. So we've got some community colleges that provide nursing. They're now going to hospitals and saying, can you give us some of your nursing supervisors on a part-time basis to come in and be instructors? All hands on deck. What can that look like as a national policy from your perspective as in the healthcare arena?
Congressman, we're already working that. HRSA is undertaking a number of efforts, so we're talking to states and those in the profession about best practices. We're also using SAMHSA.
Wrap up. I'm sorry. We're trying to keep your own time so our members can ask questions.
We'll continue the conversation.
I gaveled myself down, so I'm going to. Chairman Morris Roger, you're recognized for 5 minutes.
Thank you, Mr. Secretary. Last week, this committee advanced my bill, the Protecting Healthcare for All Patients Act, which would ban QALYs and other similar measures in federal healthcare programs. And I'm grateful for the hard work of your team to modify the bill language to resolve all outstanding issues and help us towards a shared goal of removing discrimination in federal health programs. Prohibitions on QALYs and other similar measures already exist in Medicare and the Inflation Reduction Act. Since we already have an additional ban in place for Medicare, do you think it would be appropriate to ban these measures in all other federal care programs like Medicaid?
Madam Chair, can ban what?
QALYs?
Oh, I know that we already have them banned in Medicare. We do
Okay.
not use them.
Thank
And I
you.
believe that there's an effort.
Thank you. I'm going to take back reclaiming my time. I have a lot to get through here. Some questions were raised about equal value life years gained. Do you view the equal value life years gained metric as discriminatory?
Congresswoman, we don't use those kinds of measures. I'm not
Okay,
sure what the
thank you.
reference is to.
Okay, very good. Thank you. Secretary Becerra, can you tell me how many additional resources you provided to, in the words of President Biden's executive order on promoting competition, quote, support existing price transparency initiatives for hospitals, other providers, and insurers?
I think my answer is probably going to go longer than you'd like, but we are engaged in quite a few activities with regard to price transparency, and I could go through a list of them. I could also tell you how we're trying to engage real soon with companies on price negotiation to get the best price for pharmaceutical drugs.
Okay, just reclaiming my time. If it is a priority, why has there only been 2 penalties issued to hospitals in more than 2 years, despite numerous academic third-party studies, your own agency demonstrating significant noncompliance?
Are you talking about the price? I mean, the price transparency laws that are in effect?
Yes.
Madam Chair, as you recognize, that law was only implemented recently by this administration. It's taken a while. The industry has to come forward and come up with plans on how they're going to show their prices.
Okay.
It differs by region.
Okay, thank you, thank you. We're going to go to work on this, and we're going to work on this together, and we're going to get it done. Okay. Wanted to move on to Medicare. The administration recently proposed Medicare Advantage changes that will reduce risk adjustment payments to plans. You've characterized these changes as reducing overall overpayments to plans. Reductions in these types of Medicare payments constitute a cut to Medicare?
These insurance companies will get more money this year than they got last year. That is not a cut.
Okay, thank you. In my opening statement, I alluded to site-neutral payments, a bipartisan policy that would reduce Medicare spending and what seniors pay by having Medicare pay the same for services regardless of location. If lowering payments to plans isn't a cut, would you characterize such a policy as a cut to Medicare? Site-neutral payments?
Obviously, different regions have different pricing. We have to make sure that what we're doing is doing a fair evaluation of what the cost of a service or
Okay.
product is in
So,
healthcare services.
thank you, appreciate that. We found an area of agreement, I think. President Biden, Speaker McCarthy, and us were agreeing on not cutting Medicare, and it appears that we can agree on some payment reductions that don't constitute cuts. So, would you commit to working with us on bipartisan approaches to address payments that are higher than they might need to be?
Absolutely.
Okay, thank you. Just last week, CDC released 25 nearly documented statistical numerical errors in its COVID-19 data. 80% of these errors exaggerated the severity of the COVID-19 situation. And it's especially concerning that the impact that this had on children. 94% overstated the risk to children. And in less than 50% of these instances did CDC ever fully correct the error. So can you speak to this report on errors and commit to specific actions you'll take to ensure that these are corrected?
The CDC has always attempted to be as transparent as possible. The information, the data they provide is essential for
Okay.
states and our consumers.
Thank you. So we'll work on that together too. And then finally, I just want to close by saying I'm concerned about, on one hand, we hear the administration talking a big picture on curing cancers, fighting Alzheimer's, and yet, unfortunately, we see where the action contradicts that goal. In an unprecedented action to restrict Medicare patients from accessing FDA-approved treatments across the board, no matter the promising data or the results, are disappointing to millions of patients with Alzheimer's and their families who are looking for hope. And we are going to continue to press you on this because when we finally get these breakthrough drugs, we must make them available to the people that are depending upon these drugs to give them hope. I'll yield back, Mr.
Thanks. The gentlelady yields back. The chair yields back, and the chair now recognizes the ranking member for 5 minutes for asking questions.
Thank you, Chairman Guthrie. Before I get to my questions, I would just ask unanimous consent to submit to the record the GAO report from August 2018 titled rural hospital closures, number, and characteristics of affected hospitals and contributing factors, which analyzed data from the North Carolina Rural Health Research Center and CMS, and found, I quote, that from 2013 through 2017, rural hospitals in states that had expanded Medicaid as of April 2018 were less likely to close compared with rural hospitals in states that had not expanded Medicaid. And this, of course, goes to my point that not expanding Medicaid or cuts to Medicaid are really going to starve the healthcare systems in rural areas and impact red states in a major way.
Without objection, so ordered.
Thank you, Mr. Chairman. I'm very proud of the historic achievements included in the Inflation Reduction Act, which I know Secretary Becerra mentioned, particularly the authority for the Secretary to negotiate lower drug prices for certain high-priced single-source drugs, as well as to cap drug prices that increase faster than the rate of inflation in Medicare Part B and D. Additionally, the IRA will cap out-of-pocket costs in Medicare Part D at $2,000 a year beginning in 2025, and beneficiaries are already starting to see the benefits of capping insulin co-payments at $35 a month, as well as no-cost vaccines in Part D. So a few questions, if you can answer them quickly so I can get to them all. Why were these provisions so important, and are you already seeing the positive impact of these changes on the ground, such as the savings generated from the insulin and vaccine provisions, Mr. Secretary?
Mr. Chairman, we are seeing immediate impact. I can tell you that every place I've gone since January 1st, I am approached by a senior who has mentioned how it's incredible that they paid only $35 for their insulin, and in December, I remember one lady specifically, it was about $112 or $117 that she said she had paid in December. She was so startled that she went to the insurer and said, "I think you undercharged me for my insulin." And when they told her, "No, that's the new price," she was ecstatic. And so that's what I'm running into. I've had people tell me stories about having to pay close to $200 for a vaccine on shingles. 1 in 3 Americans will, at some point, experience shingles. You don't want to experience it. And it's an expensive vaccine for folks on fixed incomes. It takes a big bite out of their budget. And so to find out that today, as a result of the new prescription drug law, the Inflation Reduction Act, they're paying nothing, it's great news for them.
Now, can you, again, talk briefly, because I have one more question after this. Can you talk about whether legislation extending the protections from the Inflation Reduction Act to the commercial market could be helpful in achieving the goal of, reducing drug prices as well?
Without a doubt. There's no reason why Americans should be paying 2 or 3 times more for their prescription drugs than people around the world for the same drug, and sometimes manufactured in the U.S. And so the ability to negotiate for a fair price is something that will reward all Americans.
Now, the budget notes that additional savings can be achieved by increasing the number of drugs selected for negotiation. Can you talk about why the administration supports legislation to increase the number of drugs subject to negotiation, and how this would both increase savings to Medicare beneficiaries and improve Medicare solvency?
The legislation, and we're thankful for the legislation, allows us to move forward with the first 10 drugs. We identify them this year, and by 2024, 2025, negotiate. By 2026, Americans are receiving the fruits of that negotiation and lower drug costs. And then every year after the first year, we increase another 10 to 15. The president believes that there are more than 10 drugs. There are obviously quite a number of drugs that are overpriced, and that if we move faster, we save Americans more money, and we also save the Medicare program more money.
Well, thank you, Mr. Secretary. I'm very supportive of this, and I believe that negotiating the price for more negotiation-eligible drugs will allow more beneficiaries taking high-cost sole-source drugs to see the benefits of this law. And I hope to continue to work with you on these efforts to build on the IRA and expand savings for seniors as well as those insured in private insurance. And, I know I keep saying the same thing, but, you're here talking about something that exists, which is the president's budget. And I know that, Republicans are talking about increasing spending, cutting things, but until they actually give us a budget, it's nice that they come here and criticize you and the president, but there's no alternative for us to see coming from the other side. So with that, I yield back, Mr. Chairman.
The gentleman yields back. The chair now recognizes Mr. Latta for 5 minutes for questions.
Well, thank you, Mr. Chairman, and thanks for calling today's hearing. And Mr. Secretary, thanks for being with us. I'd like to go back to what the chairman had started in his opening statement, some questions on fentanyl. My seatmate and friend from Virginia, we have the Halt Fentanyl Act that would make sure that for once and for all that fentanyl is going to be a Schedule I drug. And I just want to make sure that you're on board that fentanyl should be a Schedule I.
Congressman, as I've said to the chairman and others, FDA agrees that we need to continue the scheduling of fentanyl. I leave it to FDA to make those decisions on how it should be scheduled. And FDA would also say we need a comprehensive approach when we deal with either fentanyl or other drugs that are killing Americans.
Well, that's important because, again, when we've had roundtables and hearings in here, I think it's important to point out that one of the terms I try not to use anymore is the word overdoses. It's poisoning, especially when we're talking about fentanyl. When you look at the over 71,000 people that died last year in this country because of fentanyl, it's poisoning. We had one sheriff actually say that when these drug cartels know what they're putting in these pills and sending them north, it's not poison anymore, it's murder. And so I'd like to just go to a sentence that you have and just ask a couple of questions on it. You said NIH will continue to invest over $1.8 billion in research on opioid misuse, addiction, and pain disorders, including the Helping to End Addiction Long-Term HEAL initiative. Now, the question I have is because, again, I'm not sure exactly when this has been put into place and how long it's been going, but as we've seen the trend of fentanyl poisoning and also all drug overdoses and other sorts going up in this country to about 107,000 in 2022, that the question then is this effective? Because, again, in this committee, because we do have broad jurisdiction, when we talk about things that's online and drugs that are coming into this country, when we're being told by law enforcement, the DA and everyone else, that when drugs are coming across this border, that the cartels are making a fentanyl-laced pill for a dime that are killing Americans. And they're making $30 to $40 off each of these pills. And so, as was pointed out earlier, that when you have 18 to 45-year-olds is the leading cause of death now is when you're looking at either fentanyl poisoning or some other type of a drug overdose. Are the initiatives of this $1.8 billion being effective right now?
Congressman, thank you for the question. I think $1.8 billion is a major investment. If in the wisdom of this body you wish to give us more resources, I guarantee you we'll make good use of them. But I understand that there's a conversation about cutting, not increasing, on your side of the aisle. So I hope that what you're
let me ask though, because again, what we had testimony from parents that have lost loved ones, and the question and the problem is, again, as I said, these pills are flowing across the border, and then they're getting in through the internet, and pretty soon we can't even track where they came from. But when somebody buys one of these pills, a younger person, they're thinking they're getting XYZ, and it turns out a fentanyl-laced pill. What's the department doing to warn Americans? Because again, with that $1.8 billion, you do a lot of information out there. Is what's going on? It's warning people, kids especially, don't buy anything on the internet. And the reason I bring this up, it's been a few years ago, but I sponsored the track and trace legislation. And what that legislation did was to make sure from the time that a drug was manufactured, the time it was delivered, we would know every stop that it wasn't counterfeited or adulterated along the way. So, that's hopefully for a prescription drug or something else that's flowing naturally and legally through, that's people know what they're going to get. But how are we warning people online that are online today buying these pills that it's not a counterfeit or a knockoff? This drug could have, or this pill could have fentanyl in it that will kill you. And this is the problem. When we're seeing the numbers going up, and so that's my question on this is that, you understand research and misuse and addiction and pain disorders, but how are we getting the word out that people don't do this?
Congressman, much of that work is actually done not by NIH, but by SAMHSA, our Substance Use and Mental Health Agency, which deals with that. And they are working with states and local entities that are actually doing the work on the ground to support some of those efforts, to inform and to do the surveillance. They're also taking on best practices, using evidence-based practices. For example, fentanyl strips are now being made available. We are finally supporting that at a national level because we know it saves lives. You heard the news today that Narcan is now going to be available over the counter. The FDA has made that announcement. So we're doing the things that we can at the federal level to support the work that's done on the ground at the local level.
My time's expired. Are you back?
And the gentleman yields back. The chair now recognizes Mr. Cardenas for 5 minutes for questions.
Thank you, Chairman Guthrie, and also Ranking Member Eshoo for having this important hearing. And I appreciate the opportunity to discuss in front of the whole world, Secretary Becerra, what we are doing proactively in many areas. And I really appreciate the budget that the President has put forth. And I'm thrilled to see that the President has emphasized in his budget requests placed on funding for 988 and the broader continuum of crisis care in America. The 988 Suicide and Crisis Lifeline is saving lives by providing urgent and timely responses to individuals in crisis. It's a key starting point for the crisis continuum, but it's not enough to just have someone to call. When someone calls 988, we also need someone to come and somewhere to go when an individual requires greater mental health support. I'm particularly excited to see requests for robust funding for mobile crisis response grants, so that trained mental health professionals can be the first responders to mental health emergencies. And I would hope that my colleagues who represent much of rural America are excited about the opportunity to have mobile crisis response grants put out in every corner of this country, especially in rural America. Secretary Becerra, why, maybe in your opinion, is it so critical to have a robust crisis care infrastructure in our country?
Congressman, thanks for the work that you have done over the years on this issue. The reason it's so important to have a crisis care system is because people don't have a mental health crisis just from the hours of 9 to 5. There has to be a place for them to go after hours. They have to know that when it hits, there'll be someone there to catch them. And a 24/7 crisis care center is the best way to make sure not only do we save lives, but keep people from harming themselves.
I want to make it clear. I think you and I are talking a little bit inside baseball. When you and I are talking about crisis care, we're talking about mental health crisis. Right now in America, or before last year, if there was a crisis moment in America, maybe somebody was off their meds and their mother called 911, who would show up? Maybe there would be a healthcare professional show up, but 99% of the time it was the law enforcement officer who, even they and we all agree, they are not trained to deal with mental health issues. We need mental health professionals to show up to the moment so that we can actually help the situation instead of unfortunately have a critical moment where it even gets worse. So when it comes to mental health in America, we are making improvements, and 988 is in fact a big step in the right direction. And hopefully Americans will take 988 for granted, like people expect that when they call 911, and it happens everywhere in the country, someone comes when they call 911, and that's what 988 is about. What resources are still needed to build out our crisis infrastructure when it comes to mental health and ensure that everyone, regardless of circumstance, can access crisis services, including the LGBTQ plus community and individuals and people with disabilities and those whose primary language is not English?
Congressman, on 988, I'll just mention we need to get states further invested in it because this is not a national program. Only because the President and Congress has been so willing to help the states have we been able to make it work so well. But if the states have to make commitments to have permanent, stable funding for 988 in their jurisdiction, and so that needs a lot of work. We're expanding access under 988 in languages other than English because we know a lot of folks need that communication. We are doing a call that's specific, a line that's specific for veterans. And so we're going to try to make sure we're approaching as many people as we can, including our LGBTQI plus community as well. Crisis care, we need to fund further crisis care so that it's available 24/7. We have to make sure that there is follow-up service when someone does reach out and make the call. And so we're working as hard as we can to make sure certified community behavioral health centers receive the support to be able to expand.
Locally in every community, correct?
That's correct.
Okay, so when somebody calls 988, they're not in California talking to somebody in 5 states over or what have you. make it local, make it robust. And you're absolutely right. 911 is in fact a local funded program supported by the federal government, but it's primarily supported by locals.
By the workforce as well. We're working to expand the workforce because if there's a shortage in the healthcare workforce, it's even more acute in the mental health and substance use workforce.
Absolutely. And in order for us to have more mental health force workers ready and to fill those positions and do that work, we need to make sure that the local schools and the local activities are actually educating people so they can actually be in that position. My time having expired, thank you so much, Mr. Secretary. I yield back.
Thank you. The gentleman yields back. Chair now recognizes Mr. Griffith for 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Mr. Secretary. Mr. Secretary, many of us on both sides of the aisle are concerned about the workings of the Office of Refugee Resettlement, ORR. When the Oversight and Investigations Subcommittee holds a hearing on ORR to address our questions and our concerns and looking for answers, are you willing to come to the subcommittee to testify? Yes or no?
Absolutely,
Yes.
Absolutely, Congressman.
Thank you very
I hope we
much.
can work out a good time. Just make sure I'm available.
Yes, sir. We'll work on that. Also, Mr. Secretary, on another subject, the President recently signed into law a bill that passed unanimously in both the House and the Senate to declassify information related to COVID-19 origins and the Wuhan Institute of Virology. When do you think HHS will be able to comply with the law? And I'm not saying to anybody, I don't want anybody to misinterpret that I think you all are tardy, because this has been like a week.
Yeah.
But I'm just curious as to what kind of a timeline there is.
Thank you. Thank you for clarifying. We will try to move swiftly because we're as anxious to get information out there as you are. There are a lot of entities around the world who aren't being transparent. We want to make sure we're transparent.
Let's switch gears and talk about some of the entities that aren't being so transparent. According to an article in the May 2021 China Daily, Minister Ma Xiaowei of the National Health Commission of the People's Republic of China said during a phone call with you that China was willing to deepen cooperation with the United States in fighting against the COVID-19 pandemic. What cooperation has China's National Health Commission provided?
Congressman, what I can tell you is I hope that those words ring true, that they will try to be more transparent and more collaborative, because we still are seeking information from China and about their research and about the information they have about the first infections that they saw of COVID in their country.
Yeah, this is very critical, and it's not just because we want to beat up on the lab or beat up on anybody else, but we have to have this data to try to figure out what we can do to try to prevent a future problem of a similar nature. Would you agree?
There is no way you're going to trace the origin or figure out how to address these and find remedies unless you have all the comprehensive information that lets you determine what is driving this.
In that regard, have you had communications with Minister Ma since May of 2021?
I have not, and it's been difficult to keep those communications going. We have made requests. We've done it directly and through the World Health Organization, and we're hoping that we will continue to see words that talk about doing more together.
And speaking of the World Health Organization, have they been cooperative? Because early on, it looked like they were kind of running interference on behalf of the Chinese, and I'm just wondering if that's gotten any better.
I would say that the WHO and the Director General have been making efforts to try to secure information from China. And I believe that they've tried to be as transparent as they can. They've done a good job of bringing so many countries together to deal with COVID. And all of us are seeking as much information from whatever the source is, not just from China, that we can get so we can figure out where we go from here with COVID.
All right, I appreciate that. Mr. Secretary, last year, Republican leaders McMorris Rogers, Mr. Guthrie, and myself wrote to you asking to provide more transparency about your meeting calendar. You declined to provide the information. However, other cabinet secretaries have publicly posted their calendars on the websites of their departments to dispel questions about your level of engagement on HHS matters and to build public confidence. Will you commit to making your work calendar publicly available like other cabinet secretaries do?
Congressman, we will provide the information like my work schedule and so forth as those requests come in and as the law requires.
Yeah. And I look forward to the OR meeting that I referenced earlier because there are a lot of questions that we want to get to. The New York Times article is concerning. Further, as you know, last year I raised issues about the vetting process for where we're sending these children. I want to look into that more because I think on both sides of the aisle we want to make sure we may not agree on how they got here, how they crossed the border, but once they're here, we have an obligation to make sure these children are in safe environments where they're not being abused or exploited. You would agree with that, would you not?
100%.
All right. And I look forward to working with you to try to make OR better and to figure out what we can do to live up to at least a minimal standard of security for these children. Thank you, Mr. Chairman. I yield back.
Gentleman yields back. Chair recognizes Dr. Reese for 5 minutes for questions.
Thank you. Mr. Secretary, it's good to see you. Thanks for being here today. As you know, I'm committed to protecting Medicare for seniors in my district and across the country and to build on the policies that we passed last Congress to make healthcare more affordable. This includes the Inflation Reduction Act, which lowers drug prices for American seniors. The President's budget discussed today further improves seniors' access to life-saving care by further lowering prescription drug costs for our seniors. On the contrary, Republicans have repeatedly tried to cut Medicare, and leading Republican plans have proposed to slash Medicare funding and increase the age for Medicare eligibility. Under the leading Republican plan, seniors would be subject to thousands of dollars in additional out-of-pocket costs. Secretary Becerra, can you briefly discuss how slashing Medicare funding would harm seniors?
Congressman, I think everyone knows how much Medicare has lifted seniors out of poverty, how Medicare has saved lives, and to now see the chance of that progress eroded would be devastating. That's why the President came out with a budget that actually not only protects all those benefits, all those services for today's seniors, but assures that it'll be there for the next generation as well.
Thank you. And so can you expand on how the administration intends to protect seniors and lower their health care costs?
Well, first, everyone now is aware of the $35 cap per month of insulin. That is a tremendous saving. I mentioned earlier the money that's now being saved by no out-of-pocket cost for preventative vaccines. That is saving a lot of Americans a lot of money. We're now beginning to watch the pricing that the drug companies put out for their drugs if they go beyond the rate of inflation. The law that you helped pass, Congressman, lets us tell those companies you owe back money to the Medicare system because you charge more than the rate of inflation for your prescription medication. And as you know, in the next coming years, we'll be able to negotiate the prices of prescription medication.
Thank you. You know, in addition to affordability, I'm also concerned with access. Medicare physician pay and its impact on patient access to care remains a major issue for my constituents. In fact, adjusted for inflation in practice costs, Medicare physician pay actually declined 26% from 2001 to 2023, or by 1.8% per year on average. Nonpartisan government stakeholders are recognizing the damaging impact these cuts are having on patient access to care. The 2021 Medicare trustee report states that, quote, absent a change in the delivery system or level of update by subsequent legislation, the trustees expect access to Medicare participating physicians to become a significant issue in the long term, unquote. To help address this growing problem, I'm working with my friend and colleague, Dr. Bouchon, on legislation to provide an annual Medicare payment update tied to inflation, as measured by the Medicare Economic Index, the MEI. Even the March 2023 MedPAC report to Congress includes recommendations that Congress increase the 2024 Medicare physician payment rate above current law with an inflation-based payment update tied to the MEI. It is critical that we move away from a system where every year there is uncertainty over potential cuts, threatening access for seniors across the country. Secretary Becerra, can you discuss the pressing financial instability facing physician practices, including the threat of yearly cuts combined with rising costs?
Congressman, and I know you know this well as a physician. My wife, who's a physician, also will talk to me about this, and I know several members of this committee are physicians. It's tough. I mean, the workforce is strained. That's not different for doctors or nurses or other health professionals. We want to encourage people to go into these professions. We saw with COVID how important it is. And what I will tell you is I now will speak to you as a former member of this chamber, going through this exercise every year of trying to figure out physician payments. It's not just a headache, it's a real threat to how physicians can plan their life forward. And so I hope Congress is able to work in a way that gives us some certainty for physicians and others moving forward of what they can expect in terms of payment. I wish I could tell you we could do more, but we're constrained because we have to be budget neutral in whatever we do. So if we're going to increase payments in one place, we have to decrease them in another place. And so I think physicians around the world, around the country will tell you, come up with a better system.
I agree. Thank you, and I look forward to continuing our work together on these important issues.
Thank you. The gentleman yields back, and I recognize Mr. Johnson for 5 minutes for questions.
Well, thank you, Mr. Chairman, and thank you, Secretary Becerra, for joining us today. You know, fiscal responsibility is an issue that unfortunately is easily forgotten here in the Beltway, inside the Beltway. It's too easy to spend money that doesn't belong to you. And the idea of small government and not spending outside of your means is a sentiment in very short supply these days here in this city. Earlier this month, President Biden released a $1.7 trillion budget that does nothing to change the frightening debt track that the United States is on. In fact, the administration continues to tout the fact that they're cutting roughly $10 billion in mandatory spending over the next year. But what's the catch? It's spending that is solely related to the COVID emergency. So I hate to bust the bubble, but you don't get to take credit for cutting spending on a pandemic that the president has personally claimed is already over. This spending should have ended a long time ago, but facts never seem to stop this White House from continuing its spending addiction. Today, I'm going to focus my questions and comments on the East Palestine train derailment and chemical fire that has upended the lives of my constituents in this small rural Ohio village. A little less than 2 months ago, a train carrying hazardous materials derailed in East Palestine, Ohio, in my district, resulting in a controlled release of toxic chemicals, evacuation, and massive environmental cleanup. No family should ever be faced with this type of hardship caused through no fault of their own. And right now, the biggest concern for these residents and for me is the long-term health and viability of their community. So, Secretary Becerra, earlier this month you said the administration would have a whole of government, I quote, whole of government response to the train derailment. Could you explain how that involves HHS and what you're doing on the ground in East Palestine?
Congressman, thank you. And if there are other things that we can do on this issue for the people of East Palestine, please let us know.
Thank you.
We want to be there as much for you and your constituents as we can.
Okay.
But we know those families need to
Tell us what you're doing. I'm sorry for interrupting you, but he's going to gavel me down in 5 minutes.
We were one of the first on the ground. CDC was on the ground. We were doing the assessments, going door to door to find out what people were experiencing. That information we compiled into data because we wanted to find out what the health effects might be for the families there. So we were on the ground quickly talking to hundreds of people there that were surrounding the incident. We also knew that there was a community health center that was providing most of the health care immediately to some of those families that needed help. We provided an emergency grant of $250,000 to that health center so they could continue to provide that extra care that they were not expecting to have to do. And so we continue to be on the ground. We work with the EPA and others within the federal government. I've been in touch with the health director for the state of Ohio, for the state of Pennsylvania. We'll be in touch, but please let us know if there's more we can do. We're ready.
It's my understanding our local health department is continuing its own response efforts, and you just mentioned that you're coordinating with them to ensure there's no duplication of efforts, right?
We work with them. We don't do the work. We try to support what they do.
Okay. What's the process your agency is using to communicate information to healthcare providers, particularly in regards to highly vulnerable populations such as children, pregnant women, and the elderly?
We work with the state's health department and with your local health departments because we're not the ones that are on the ground all the time, and we respect the work that they do and the relationship they have with the community. So we try to support in whatever ways they ask.
Okay. And finally, currently there has been only one SAMHSA and one HRSA grant provided to on-the-ground efforts there in East Palestine. Are you using HRSA's already existing current emergency authority to issue these grants?
That is how we got some of the immediate funding to that community health center. And as I said, we've put out the call. We've let them know, let us know if we can be more helpful. I said that directly to the health director for the state, and we are ready to try to do what we can.
Okay, thank you very much. Mr. Chairman, let it be noted, I answered your call. 30 seconds, I'm yielding back.
Thank you. The gentleman yields back. The chair now recognizes Ms. Custer for 5 minutes for questions.
Thank you, Mr. Chairman, and welcome, Secretary Becerra. Great to be with you today. The Department of Health and Human Services plays a pivotal role in protecting the well-being of our country, and this budget proposal reflects that. We all know COVID-19 took a harsh toll on the healthcare workforce, and I was glad to see the FY 2024 budget support for workforce programs across HRSA and the CDC, supporting the current workforce and investing in the future. We expanded the capacity of healthcare workers throughout the pandemic by adopting telehealth as an important tool. Telehealth not only allows a patient to receive care in the comfort of their own home, but it also empowers providers to use their skills in communities that need it most, and it's particularly important in a rural district like mine. Secretary Becerra, how can telehealth be used beyond the public health emergency to work across state lines, expanding access to rural and underserved areas?
Congresswoman, thank you for your work in this area, because it's become so essential to have access to healthcare through telehealth. Perhaps some of the greatest gains we've seen, and COVID taught us this, is behavioral health. We were having a lot of folks who, for reasons of stigma and other reasons, were not using services for mental health. And what we found is that having access to a physician or a provider at your home through telehealth made you more likely to participate, more likely to make your appointment. And so we hope that people recognize, at a time when 9 in 10 Americans believe that America has experienced a mental health crisis, that telehealth is indispensable. We need to continue to work with you, because those authorities for flexibility on telehealth, which you extended to the end of 2024, you can't have that cliff and all of a sudden have all those flexibilities expire. And so we need to work with you. We need to work with states to make sure we figure out if there's a possibility of having a cross-state provision of healthcare services, because right now a physician licensed in one state doesn't have a license to practice in another state. Telehealth has no borders, and so we have to figure that out as well.
Thank you. The budget also reflects this administration's commitment to ending the mental health and substance use disorder crisis. We made great strides last Congress, passing the bipartisan Restoring Hope for Mental Health and Well-Being Act with a vote of 402 to 20. I think it was probably the most bipartisan vote we took. While this was important progress, we know that there's still a lot of work to be done, particularly in better serving the hard-to-reach populations. I look forward to working with my colleagues on reintroduction of my bipartisan bill, the Humane Correctional Healthcare Act, that will end the federal rule that prohibits Medicaid from paying for care for people who are incarcerated. I'm also excited that Representative Tonko is reintroducing the Medicaid Reentry Act to allow for Medicaid coverage for 30 days prior to release. And I look forward to supporting Mr. Trone's legislation to allow Medicaid to cover pretrial detainees in the Due Process Continuity of Care Act. Medicaid is the largest public payer of behavioral health care, and it's essential that we defend the integrity and funding for this essential program as a bedrock of the federal budget. Right now, people across New Hampshire are rallying behind the Medicaid program as the state considers making expansion permanent on a bipartisan basis. And I know there are a number of Republican states that have just made Medicaid expansion. Medicaid expansion has been an unqualified success. It's extended health insurance to millions of low-income people, helping to make them healthier and more economically secure. I'm concerned about how some of the discussed cuts to Medicaid would affect deeply vulnerable individuals, particularly people with disabilities, seniors, and children with complex medical conditions. Could you describe what some of the consequences would be if the federal government suddenly cut funding for Medicaid expansion?
Well, Congresswoman, Medicaid has become the provider of health care for not just low-income Americans, but for many middle or lower to middle-income Americans who can't afford sometimes health care on their own. And if we were to see cuts to Medicaid, well, let's just put it this way. There were close to 19 million Americans who received health care through Medicaid that was expanded. 40 of the 50 states have expanded their Medicaid program. That's about 19 million Americans. If we were to cut those things, you would quickly see millions of Americans return to the roles of the uninsured. And I mentioned how we've never seen so many Americans have access to health care through their own insurance as we see today, more than 300 million. It would be devastating to move backwards instead of trying to get the rest of the country, the 30 or so million Americans who still are not covered.
Secretary, my time is up, but I just want to point out that that would have a devastating impact on our workforce as well. So I yield back.
Thank you. The
so
gentlelady
much.
yields back. The chair now recognizes Ms. Harshberger for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Secretary, for being here today. I want to delve right in and touch on a couple of issues which we have common ground on, and in some where there may be some disagreement. In one of our previous conversations, we've talked about how pharmacy benefit managers have exploited the lack of transparency, created conflicts of interest, distorting competition, reduced choices for consumers, and ultimately increase the price of drugs. They're really putting the screws on independent pharmacists, by the way, and you know that, sir. Is there anything in the president's budget that would address or reform the PBM industry to make prescription drugs more affordable? And that's just a yes or no.
I have to qualify because most of that reform would not be done through the budget. It would be done through the rules that we set, but we are absolutely trying to do reform and transparency.
Well, I think we can work together on that because there's strong bipartisan support in Congress to do that, especially on this committee. Let me turn to another topic that to me is an immediate threat, and it's about mail order of oncology drugs. Recently, HHS, through frequently asked questions, implemented a prohibition on community cancer clinics from mailing their patients medicines directly, forcing patients to come into the clinic. Now, HHS waived this restriction through the public health emergency, but it's set to take effect again in May, and this is extremely disruptive to cancer care. And I've talked to these oncologists personally. And I want to follow up with more details in a written letter, but do I have your commitment to work with me and other concerned members in Congress to resolve this issue?
Absolutely, you have my commitment.
Okay, fantastic. We'll get that letter to you. Now let me move on to something you might not, well, you're probably familiar with, and I want to ask you a couple of things about the federal workforce under your department. Now, you have about 83,000 federal employees under the department. Is that correct?
I'm sorry?
You have about 83,000 federal employees under your department.
That's correct.
And about 4,000 of those employees work at CMS headquarters in Woodland, Maryland, correct?
I'd have to check the number, but I'll assume that you have a correct number.
Okay. Well, I want to show you this photo, and I'm sure that you are absolutely familiar with this photo. It's an empty parking lot at CMS headquarters in Woodland, Maryland. This photo was taken on a Monday, March 20th at 10:40 a.m., and Mr. Secretary, I assume that a good number of people will drive to the headquarters at CMS. And why is the parking lot empty and on a Monday morning at 10:40 a.m.? My question is, do you have a breakdown of how many employees at CMS do telework on a regular, consistent basis, sir?
Congresswoman, we are working full-time. We've been working full-time since the pandemic. The fact that so many Americans have a vaccine that they've been able to use to save their lives.
Can I stop you just a second? Will you get me the data on that?
I can certainly get you data on the workforce, and we can try to respond to some of those questions.
I would love to know how many people are working from home. I see in the president's budget, CMS is requesting thousands more dollars for office rent. And my question to you is, why should we even consider more funding for office rent when you don't know how many people are showing up at the office? And there's also other areas in your department that you're potentially looking to get rid of property. You know, and let me tell you this is what the American people see. They see an image or a situation that does not resemble good government. And it's not only outrageous to many members in Congress, but it also is like a slap in the face to the Americans and the taxpayers that are coming to work and showing up day in and day out, sir, because that's their job, is to be on site. And we know, we've looked at studies, people are more productive when they show up in person. And I'm a healthcare provider, and I have been for 37 years. I have to show up to do my job. So let me turn to one other thing, and I may have a little bit of time, and it's about the future of Medicare. In a recent Washington Post editorial called President Biden's Medicare Solvency Plan, and I quote, political messaging rather than a serious approach, and it places the entire burden of ensuring Medicare solvency on unpopular drug companies and high-income earners, implying incorrectly that structural reforms are unnecessary. And I'll just say this, when a Democratic administration loses the faith of the Washington Post editorial board, you know things are not going in the right direction, sir. Would these Medicare proposals do anything to prevent Medicare costs from growing at a far faster rate than GDP?
Congresswoman, the fact that the president not only maintains benefits and protects them, but also can do that for the next generation will be a great savings for all Americans who can have guaranteed health care when they need it.
Well, I'm out of time, sir, and I have a few other questions, but I'll get those to you in writing. Thank you, sir, and I yield back.
Now recognize the gentlelady from California, Ms. Barragan, for her 5 minutes.
Thank you, Mr. Chair. Thank you, Mr. Secretary, for being here today to testify. Thank you for all of your work, and thank you for joining the Congressional Hispanic Caucus on the road to talk about youth mental health and everything the administration that you're doing to address youth mental health. I'm sure we'll be seeing you to continue on the road to talk about all of the accomplishments that we've been able to do in the last 2 years that people are going to barely start to feel. So thank you for that. There is an area which we've talked about before, and I want to take a moment here to recognize the amazing advocates that are sitting in purple behind you with the Alzheimer's Association. I stand with them in support of improving access to FDA-approved Alzheimer's drugs. And I know that you've heard it from me before, but I disagree with CMS's coverage decision to tightly restrict coverage for an entire class of FDA-approved Alzheimer's drugs. And I continue to just say I think there is a huge disconnect when the FDA can approve a drug and that CMS will not cover that drug. Just recently, the VA also announced that they were going to cover one of the drugs that CMS won't cover, which is lecanemab. And so it seems to me there's just some real disconnect that we're trying to get to the heart of to see how we can fix that. It's one of the reasons that my colleague, Dr. Joyce, and I introduced the Access to Innovative Treatments Act. Our bill would ensure CMS fairly considers coverage for innovative drugs and therapies. And so this is an issue I'm going to continue to work on. My mother has Alzheimer's. She's 82. We also know Alzheimer's is one of the biggest threats that we have, especially in our Latino communities who are at risk of developing this. And I think when we talk about budgets and we talk about cost, it's also going to have a huge dollar impact, on our budget in access to care and health care. One of the good things I think that came out of what Democrats were able to do in the last couple of years is investing over $100 billion over 10 years for Medicaid, home, and community-based services. I want to thank you for that. That's something that Congress needs to continue to do so that people like my mother who have Alzheimer's can stay in their home, which they know is the most familiar place, which helps them in their development. Mr. Secretary, I want to move on to a topic that is in the public now and is so critical, and that is the Medicaid unwinding. I want to thank you for your leadership on this, and thank you for your leadership in keeping Americans covered. As a result of your hard work, more Americans have health care coverage today than ever before. Uninsured rates are at an all-time low. However, this achievement may be at risk In just a few days, states will resume reviewing all Medicaid enrollees' eligibility, a process called Medicaid unwinding, on April 1st. Last August, HHS estimated that 15 million people could lose their Medicaid if the program operates as it did in the past, including nearly 5 million Latinos who are at risk. More than half of the people of color estimated to lose coverage will remain eligible for Medicaid. In response to these staggering numbers, Congress enacted strong beneficiary protections, required additional transparency from states, and authorized powerful new enforcement tools for HHS to use to protect our most vulnerable citizens. Furthermore, more than 60 members of the Congressional Tri-Caucus, which is made up of the CHC, the CBC, and the Asian American Caucus, sent you a letter urging you to protect access to health care coverage during the unwinding. My question, Mr. Secretary, how do you plan to oversee states to ensure that they are complying with the law? And how will you commit to act swiftly to protect Medicaid beneficiaries if it is clear that a state is improperly disenrolling individuals?
Congresswoman, first, thank you for the work you're doing on this. I look forward to the partnership because you're right. There is no reason why someone who is eligible to receive insurance should lose it and not have access to medical services simply because they did not get connected in time. A year ago, I think about maybe even more than a year ago, I wrote a letter to all the governors in our country saying, at some point, we're going to be moving on from the public health emergency, and Medicaid will have to unwind, and people may lose their coverage. So let's start working together to prepare, because states, as you know, administer the Medicaid program for the federal government. We have since been following up with those governors. I now write them every month so they know where they stand. We don't want any governor to say, didn't realize that hundreds of thousands or millions of my residents were going to lose their coverage. I'm holding a copy of the letter I sent to our governor in California, Governor Newsom, that was dated March 7th. This is a letter that every governor, very similar, gets to tell them where they stand. We're going to bird dog this, and I want to say, especially to those of you who supported the law, that gives us more authority to oversee how that unwind occurs and to make sure that every state is responsible to take
Mr.
action.
Secretary, we time's expired, so we're about almost a minute over. I apologize.
I
So
follow up.
Chair now recognizes Mr. Billerica for 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate it very much. Mr. Secretary, I want to talk to you today about the health concerns plaguing the youth of our nation. We've seen an influx of illicit fentanyl and other dangerous illicit substances coming across the southern border, all while we are amid an unprecedented mental health and substance abuse crisis. Our children are being poisoned by drugs that flood across our southern border. And I always say that fentanyl is a weapon of mass destruction. Many of these children do not realize that they're even encountering illicit fentanyl. Many utilize social media platforms to purchase pills that they believe are pharmaceutical grade, but in fact are laced with fentanyl. And I know this has been mentioned before, but it's worth being mentioned again, that's for sure. The HHS budget suggests expanding the CDC's, and I quote, "What Works in Schools" program centered around health education for middle and high school students. In this program, the CDC has provided health education curriculum tools for schools to utilize to help meet the health needs of students. This 940-page document never mentions fentanyl or opioids, not a single time. For that matter, illicit fentanyl is only mentioned once in your HHS budget document, only twice in the president's budget, and I know that the chairman mentioned this as well. Is there confusion at HHS about the deadly impact of illicit fentanyl when it comes to drug overdose death? Please, sir.
Congressman, I've heard the mention of a reference once or twice in the budget. I would say to you that we are addressing fentanyl not once or twice in the budget, but 10 billion, 900 million times, because that's the amount of money that we are committing to fight drug overdose and fentanyl and opioids. And so we are in that mix. We don't have to say the word to be in the mix. And what we're trying to do is work with our communities locally to make sure they know that they will be supported by the federal government when it comes to addressing drug overdose, whether it's opioids, whether it's fentanyl. We want to be there with them.
Okay, I'll get on to the next question. Last year, you told me when I asked about the status of Medicare's transitional coverage of emerging technologies rule, and also expressed concern about CMS acting as a second gatekeeper to the FDA, particularly due to the agency's misguided NCD decision on Alzheimer's treatments. You told me that the two agencies have two separate but distinct missions, but they were committed to working together to help provide seniors with new potential treatment options. Unfortunately, in the year since, we saw you that exact opposite. Unfortunately, the exact opposite has occurred, and I know my colleagues have mentioned this as well. CMS doubled down on its policies and blocked coverage for the entire class of these treatments when it comes to Alzheimer's. How is it possible for CMS to prejudge an entire class of drugs as not being reasonable and necessary for seniors after the FDA approves these very drugs to treat as safe and effective for Medicare patients with Alzheimer's, the primary audience for these drugs? And this is hope for our Alzheimer's patients. It's hope for our families and caregivers. So please, sir, answer the question, and let's reverse this ruling by CMS. I mean, isn't FDA responsible for making these decisions?
Mr. Chairman, thank you very much. And for all Americans who are interested in this subject, not just because a family member has Alzheimer's, but just because this is the kind of thing that could hit their family at any time, I want to make sure we're clear. We're following, Congressman, the law that you all have passed. Maybe not you today or in the last few years, but the law that's in the books treats FDA and CMS differently. The standards that apply to FDA are different from the standards that CMS must apply. And so it wasn't that CMS prejudged or that it didn't follow what FDA did and said. It's that the CMS is not, by law, under the laws that Congress passed, supposed to just follow FDA or judge based on what FDA does. CMS, like FDA, must collect the evidence to make decisions. FDA makes the initial decision, is this a drug that should be put out into the market for American consumers to have access to? Is it safe and effective? CMS has a different standard by law established by Congress.
What is that standard?
Reasonable and necessary is probably the shortcut way of saying what CMS must look at for purposes of determining whether it will provide access to a particular treatment or medication.
Thanks. The time's expired. I'll let you go look because we're all interested in that, and we know a lot of people in this room are interested in that as well. So we appreciate it. Dr. Shire, you're now recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, Secretary Becerra. Thank you for being here today. Thank you for the work you've done to make healthcare more affordable and accessible for the American people. And thank you specifically for coming to my district to visit a school-based health clinic, which is pretty remarkable. And I want to thank you for including support for school-based health centers in your budget. Today, there's so many things to focus on. I thought I'd focus on healthcare access from a couple perspectives. First, in your testimony, you discussed the importance of expanding and retaining the healthcare workforce. In the wake of the pandemic, we have seen early retirements, resignations, mostly in doctors and nurses. And these shortages are already being felt in rural areas and underserved areas. I saw that there is funding in the budget for innovative approaches to train up some other parts of our healthcare system, which is great, but I just want to focus on the importance of graduate medical education, needing a bigger pipeline in order to respond to physicians' shortages. And I know it's a lengthy training, but you got to start somewhere. I've been working on bipartisan efforts to enhance both the rural and pediatric workforces. One of my recent bills with my colleague, Representative Harshberger, is the Rural Physician Workforce Production Act, which aims to put more providers and residency programs in rural areas because where people train, as you know, they stay. I was wondering if you could talk about your plans to strengthen GME and also if you could touch on pediatric graduate medical education.
Congressman, first I have to say what you just said is music to our ears at HHS. We believe that where a physician trains probably will determine where that physician practices. And so therefore, to the degree that we can drive through the graduate medical education programs, these graduate GME slots, these residency slots into communities like rural communities, low-income communities, we have a chance of ensuring that they will stay there to practice. And so we support that. Our Public Health Service Corps, we are sending more people into communities that are disadvantaged. We pay your education for 4 years of medical school or nursing school, and then you commit to 5 years of service in a underserved area, a rural community otherwise. So we're going to try to do what we can.
Music to my ears. Thank you. The music to my ears.
Yes.
You know, I wanted to know, just this week in a meeting, I heard that there are some new restrictions on residency funding so that cannot be used to have residents, say, at an urban hospital, do some of their rotations in rural areas unless there's special set-aside funding. So if you could just take a look at that, that would be counter to what we want to do in rural America. Let's see. I also wanted to talk about retaining the workforce that we have. I want to associate myself with the comments made by Dr. Ruiz about the continuing threats of Medicare cuts and how that impacts the workforce, and would just ask that at a minimum, we don't cut, and ideally have it keep up with inflation, because there is definitely a squeeze.
And Congresswoman, recognize that we have to live with a neutral process. So if we increase one place, we have to decrease somewhere else. We don't have a choice. We need you to change that.
Maybe that neutrality is the problem. I'm happy to talk with you about that and to work on that. Let's see. I also wanted to talk about Medicaid reimbursement, which is even lower than Medicare reimbursement. And I have a bill, the Kids Access to Care Act, which boosts Medicaid to Medicare reimbursement, which I am working on, and I hope you'll pay attention to that too. And lastly, this is a big thank you just about the importance of the Affordable Care Act and the subsidies that we included in the Inflation Reduction Act that have really made a difference at the kitchen table for my constituents. Premiums are at an all-time low. Enrollment is at an all-time high. In part of my district in a rural area, 82% of people on ACA plans saw their premiums reduced by an average of $450 a month, and that matters at the kitchen table. So I want to thank you. I am short on time, but if you want to touch on the importance of making those subsidies, those tax credit enhancements permanent, I would love to hear a couple words.
Congressman, it's all about peace of mind. If you know that you can take your child to the hospital when it's necessary and you don't have to fear going bankrupt or not being able to pay the mortgage, it's peace of mind. And every American should have that. There's no reason why some families in America can't make that decision the right way, which is give my child the care he or she needs.
Thank you.
Thanks.
I yield back.
Thank you. The gentlelady yields back. The chair now recognizes Mr. Hudson for 5 minutes.
Thank you, Chairman. Mr. Secretary, thank you for joining us today. I have a number of questions, so I think I'll jump right in. For the last several years, FDA has allowed certain e-cigarettes and vapor products with pending pre-market tobacco application to be sold. Unfortunately, FDA has failed to publicly communicate in a transparent manner which of these products have filed a PMTA and therefore are allowed to remain on the market. The result is marketplace confusion and a related proliferation of illegal vapor products on store shelves. In addition to the agency's failure to provide regulatory clarity to consumers and retailers on what products may be lawfully on the market, FDA's Center for Tobacco Products is also facing an unprecedented backlog in new product applications. While I understand that CTP is still in the process of reviewing applications for both PMTAs and non-tobacco nicotine products, some applicants are experiencing historic wait times in hearing back from the center on the status of their applications. This does affect consumer and industry confidence in the administration's ability to bring innovative next-generation products to the market. Mr. Secretary, does the administration have any plans to use your enforcement discretion to remove these illegal e-cigarette and vapor products, a majority of which come from China, from the market? And additionally, will this administration commit to ending the confusion surrounding the legality of these products?
Congressman, I look forward to working with you on this subject, because if I were to ask you, how many applications do you think FDA received to put a vaping product on the market, what would you say?
Hundreds.
Hundreds? Over, I think it was 5 million.
Wow.
And so that's been the issue. We were flooded with applications, some really not worth the paper they were written on, but this way they could try to escape having direct action taken against them, enforcement action. And so what I can tell you is FDA has disposed of well over 90, I think close to 98% of all of those claims. They're moving hard. It's just that you haven't seen that because so many of them they had to dispose of were essentially frivolous. Now we're being sued because there are companies that don't like the determinations we've made. So I would look forward to working with you, because we are doing everything we can to get some of these products, which you and I know have no reason to be on that shelf, a grocery shelf. We need to take them off. So I look forward to working with you on that.
Absolutely. I commit to work with you on that. Thank you. What is CTP's plan to mitigate the current backlog, though? I mean, I realize it's larger than I thought it would be, but what's your plan for?
The backlog, the backlog is not so much a backlog, it's we're being delayed by litigation. We can't move forward on a particular product. The larger companies are the ones that are putting lots of attorneys in front of us and suing us. They're the ones that have the majority of the products. And because we are in litigation, because we're being sued, it essentially puts a halt on a lot of our enforcement. But we have taken recent enforcement actions. We are working with the Department of Justice to help us enforce on those actions. And as I said, I'd love to have that conversation with you, because we could use some help in letting the public know what's really going on out there.
Yeah, great. Well, switching gears in the little bit of time I have left here, I have the honor to work with my colleague Anna Eshoo on reauthorization of the Pandemic and All Hazards Preparedness Act, and we look forward to working with you in a bipartisan manner on this important reauthorization. A recent GAO analysis tracking COVID-19 funding and spending found Congress has appropriated nearly $350 billion to the Public Health and Social Services Emergency Fund, also known as POSEF. This funding was intended to support and improve the nation's preparedness and response for COVID-19 and other public health emergencies. According to the report, as of January 31st, there remains about $20 billion in unexpired and unobligated funds within this fund. Just this morning, the Bloomberg reported, based on a breakdown directly from the White House, that over 98% of the money from COVID relief bills, including this fund, have been committed, leaving about $4.5 billion. I then learned from the appropriations counterparts this morning that there's actually approximately $5 to $6 billion unobligated as of March 20th. Could you help us provide a little bit of clarity here? I think this committee deserves a little bit more information on an accounting, a summary of what's obligated, what's not, and what HHS's plans to allocate and distribute all this unspent money is.
Yeah, and Congressman, I commit to follow up with you on this, because I know we're going to run out of time. But what I will say is this: first, thank you for the leadership you've shown on PAPA, because I think what we're trying to do is build that infrastructure. We can get back to you on the actual dollars that are left. 96% of all of the COVID dollars have already gone out the door. The 4 to 6% that remain are unobligated, but are in the pipeline to be, signed on the dotted line. So there's not a lot of money that's uncommitted. Unobligated make it sound like it's not yet committed. It really is. But I can talk to you. We can go through the numbers. But what I would really love to talk to you about is how we follow up on PAPA, because what we need to do is strengthen our domestic production. We have to secure our supply chains. And I suspect you know all these things, so I'd be interested in soliciting your support.
Thanks.
Absolutely. Look forward to working with you. And Mr. Chairman, thank you. I yield back.
The gentleman yields back. The chair recognizes Ms. Blunt Rochester for 5 minutes.
Thank you, Mr. Chairman, and thank you, Secretary Becerra. Good to see you. Thank you for joining us in Delaware to focus on child mental health, and for joining us today to discuss the President's Fiscal Year 2024 budget for the Department of Health and Human Services. I'm pleased that a few of my colleagues have touched on workforce issues, which underscores how important we think this is. But I want to focus specifically on the nursing workforce. With over 5 million people nationwide, nursing is the nation's largest healthcare profession. Therefore, a robust nursing workforce is critical for improving health, economic security, and equity in our country. During the COVID-19 pandemic, the already overstretched nursing workforce struggled with a host of new and intensifying challenges, and now they are leaving the profession in record numbers. Secretary Becerra, the President's budget outlines several proposals to reduce healthcare workforce shortages, including the nursing workforce. Can you discuss why innovative approaches to strengthen retention and address healthcare workforce shortages are necessary?
Congresswoman, it's hard to have good healthcare if you can't find a good healthcare professional. And we've already had lots of discussion about how it's become tough, whether physicians, nurses, other healthcare professionals. And so we're gonna be in this game for a while because we need to support these efforts. We are providing additional funding for the National Health Service Corps, which, as you know, helps put professionals in some of our most disadvantaged communities. We are increasing graduate medical education funding. We are providing scholarship and loan repayment programs for clinicians who return to practicing in underserved areas. We are beefing up primary care physicians. We're doing quite a bit.
Great, thank you. I'm concerned that the nursing landscape is evolving more rapidly than our current methods of data collection and analysis. And I'm also concerned that we don't have a centralized, dedicated body to study and advise on ongoing nursing workforce trends as they occur. What is the administration proposing to ensure that policymakers, healthcare leaders, and educators have up-to-date and actionable information on emerging nursing trends?
We're in the process of fielding the National Sample Survey of Registered Nurses, which will give us the data we need to figure out where we are, what we need to do. We're going to work with HRSA to try to make sure that we put resources into those areas that help us beef up the workforce, and we'll look forward to working with you.
And how is the administration working with and supporting state-based entities like nursing workforce centers that use a local lens to address the nursing shortage within their respective states?
Well, they're our principal guides because they know where we have to put the resources, where folks have to be, and so we intend to work closely with them.
Thank you for that answer. I believe that improved federal and state coordination is needed to monitor nursing shortages, coordinate strategies to alleviate the pressures on the nursing workforce, and advise stakeholders. I'm glad to share that Congresswoman Young Kim, Senator Merkley, and Senator Tillis and I introduced the bipartisan Nursing Workforce Center Act to do just that. I look forward to working together with you on this and other healthcare issues. Switching gears, health centers are a critical part of the healthcare safety net, treating a sicker, poorer, and more diverse population than most other healthcare providers. The President's budget includes several proposals to improve the reach of health centers by expanding mental health and substance use disorder care, increasing hours of operation, and funding new access points for high-need areas. Can you describe the President's proposal and explain to us why enhanced funding will increase access to affordable, comprehensive, and high-quality primary care services?
Congresswoman, as you know, some of the real champions and stellar performers during COVID were our community health centers. They stepped forward and provided care to people who didn't have insurance, who couldn't access the regular care through a physician's office or a hospital, and they did the Lord's work when it came to saving lives in COVID. We have put additional resources, quite a bit of money into these centers, the 1,400 or so health centers around the country. They service tens of millions of Americans, and they're proven. They're successful. We're going to continue to fund them. We're increasing funding. We want them to get more into behavioral health. Yeah. They're limited in their funding, so sometimes they can't do certain services, but we hope we can help them get there.
I'm really pleased again to see the expansion of also hours and access, because that's really important too. And I want to thank those who are here today from the Alzheimer's, our patient advocates, and others. We look forward to continuing the partnership. Thank you, Mr. Chairman, and I yield back.
Thank you. The gentlelady yields back. The chair recognizes Dr. Bashan for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Secretary. As my colleagues heard yesterday, one of my legislative priorities is to increase transparency and accountability in the 340B program. In a letter from 2020, you described the 340B program as, and I quote, for public hospitals, community health centers, and others serving indigent patients. Do you still believe that?
I do.
Great. I'm sure you may have read a New York Times article, and there's other articles and other sources from this was from last September, describing how certain large hospital systems have bought up 340B eligible entities in low-income areas and then used this location to obtain 340B eligibility in their facilities in more prosperous areas and essentially pocket the profits and fail to use this money to help patients as the program was intended. Do you agree that the 340B program participants should be accountable for how they use savings from the program?
Absolutely.
In 2018, as Attorney General for California, you sued Sutter Health, one of the largest hospital systems in the state, alleging that Sutter aggressively bought up hospitals and physician practices and exploited that market dominance by raising prices. Certain Sutter hospitals, including Sutter Davis, Sutter Medical Center Sacramento, and Alta Bates Summit Medical Center, participate in the 340B program. If Sutter was failing to meet your expectations as a, and I quote, public hospital, community health center, or other provider serving indigent patients, should it continue to be a 340B designated facility? That's a complicated question, I understand.
Yeah, but I'm glad you asked it, because what we don't want is to find that there is opaqueness, there's little transparency in how money's being used. That 340B doesn't have the transparency we need. What I will tell you, with Sutter Health, we found that they were engaged in practices that were stifling competition, increasing prices.
Yeah.
That's not what we want. And we want to make sure that on 340B, we're not driving pharmacists out of business. We're making sure community clinics can receive the medicines they need for their patients. We're going to do what we can to make it more transparent.
Yeah, I mean, the whole point of that line of thought right there that I had was to show that you really just don't know whether they're acting well in 340B or not, because there's no transparency, right?
That's right.
In 2014, Kathleen Sebelius, then Secretary of Department of Health and Human Services for the Obama administration, testified before the Senate Finance Committee on the President's FY 2015 budget. In response to a question on 340B, she said, and I quote, "It had been expanded beyond its bounds." At that point, there were $9 billion in sales in the 340B at the 340B price. In 2021, there were $44 billion in sales at the 340B price. The number of covered entities sites has more than doubled since 2014 to 50,000 sites, and now more than half of all hospitals in America participate in the 340B program, according to MedPAC. I do want to say, though, I failed to mention that, I'm a huge supporter of 340B if done properly. My community hospitals need this program. My intent is to make it transparent so that it doesn't continue to struggle and jeopardize their participation. But it seems to me that logically, such an expansion would also mean exponential growth in the amount of charity care and other patient benefits. You would think that was the program was intended, right? But that's just not the case that we've seen over the last 8 years. So what are your thoughts on that?
So we're trying to do reforms in 340B. We need your help to have statutory authorities to make some of these changes. We know that there's been a lot of lawsuits filed because of 340B. What I will simply say to you, compliance, transparency, two crucial aspects of making sure.
You need legislative action for some of that?
A great deal of it.
Yeah, well, I'm working on that. I want to talk briefly about the No Surprises Act. As you know, this took the patients out of the picture. They no longer get surprise medical bills from out-of-network providers, which is a tremendous success. However, you probably might imagine I was disappointed in the implementation from the agency, which I feel didn't follow congressional intent. I know the people on Capitol Hill that didn't get their way now are trying to do it through the agencies. I know that. So I would just, I don't have much time, but I would hope that the intent of the law was to have a balanced approach between the providers and the insurance companies. We recently heard in the IDR situation, the dispute resolution, that even though providers are winning those cases, we still don't have insurance companies actually paying after they've lost. So we need to see what we can do to make sure that happens. With that, I yield back.
Thank you. The gentleman yields back. The chair recognizes Ms. Craig for 5 minutes for questions.
Thank you so much, Mr. Chairman, and thank you so much, Secretary Becerra, for taking the time to answer our questions about HHS's proposed budget. It's so good to see you again. I had to step out for a few minutes of our hearing, but I'm just wondering, did my colleagues on the Republican side of the aisle issue a budget while I was away?
No, Congresswoman.
Okay, good. I just want to make sure I was up to date. I want to use my time today to discuss the mental health and substance use disorder crisis currently facing our nation. I represent the 2nd Congressional District of Minnesota. Our state is home to some of the most recognizable names in healthcare, including the Mayo Clinic and a host of medical technology companies. We consistently rank in the top 10 of all states for access to and quality of care, and we've recently emerged as a beacon of reproductive and gender-affirming care in a country where states have grown increasingly hostile toward the concept of individual choice and freedom. In short, in Minnesota, we have a lot to be proud of. But even as Minnesota operates on the cutting edge of healthcare, I'm hearing from my constituents that mental health and substance use disorder-related crises are only rising. Often, our law enforcement officials, our healthcare workers, and our teachers are being forced to intercede outside of their areas of expertise to de-escalate dangerous situations. And it's causing a malicious cycle of mental stress for both them and the people in their care. According to a recent analysis published in the Minneapolis Star-Tribune, which I would like to ask to be entered into the hearing record, the number of behavioral and mental health patients transferred from hospitals in the Twin Cities area to out-of-state facilities more than doubled from 66 in 2017 to 154 in 2021. Further, hospital-based mental health care workers are in short supply, with 80% of Minnesota counties designated as areas with a mental health shortage. From 2011 to 2021, the age-adjusted death rate due to opioid overdose in Minnesota increased from 5.3 per 100,000 to 17.9 per 100,000, more than threefold. I'm proud of the bipartisan work we've done on the Energy and Commerce Committee to improve mental health across the nation. I believe we have to attack these overlapping national crises head-on through a comprehensive whole-of-government approach. So, Secretary Becerra, can you describe how the department coordinates with other agencies like the Office of National Drug Control Policy and the Drug Enforcement Administration?
Congresswoman, thank you for the question and for the work that you've done on this issue. Because drugs fall under the jurisdiction of Health and Human Services as medicines, and because they fall under the jurisdiction of the Department of Justice when it comes to enforcement of our laws, drug laws, we have a joint effort that takes place on some of these matters. Oftentimes, we find that in trying to move in a direction, for example, making medications more available that might be listed as harmful drugs or drugs that can be abused, we find that law enforcement and the health sector don't always see eye to eye. DOJ, DEA, ONDCP, Office of National Drug Control Policy, all of us working together with HHS and others, we try to make sure that we're consistent in the way the federal government handles this. For HHS, we want to make sure we're concentrating on health and making sure that whatever we do with our policy on drugs, it provides for the best outcome healthcare-wise. And so we work with our different agency partners to make sure we can move forward. That's why, for example, on the X waiver, we were able to make it possible for physicians to actually prescribe treatments that could help someone survive an addiction, at the same time wouldn't put themselves in jeopardy of being accused of actually trying to feed a drug habit.
Mr. Secretary, I just want to end with, I'm incredibly pleased to see you request $190 million in increased funding for 18,000 new behavioral health providers and expand Medicare coverage of and the payment for additional behavioral health professionals. We appreciate your continued focus on these areas that are going to help support underserved communities and in particular rural areas. So appreciate it, and thank you for coming.
Thank you.
I yield back.
Thank you. The gentlelady yields back. The chair now recognizes Mr. Carter for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. It's always good to see you. Mr. Secretary, as you're aware, we've had quite a bit of consolidation in health care here in the recent years, including and certainly not limited to in pharmacy and in drug pricing. And I'm very concerned about that. I'm very concerned that now we have three PBMs that control 80% of the market. And those PBMs, all three of those, are owned by an insurance company. The insurance company not only owns the PBM, but it also owns the pharmacy. That vertical integration is something that I've been asking in the 8 years that I've been in Congress for the FTC to look at. Finally, last summer, they agreed to do a 6B study, and they are looking at that now. But it's not just in drug pricing. It's in healthcare altogether. It's also with hospitals. There's been almost 1,800 hospital mergers between 1998 and 2021, leading to about 2,000 fewer hospitals in this country than we had before. This consolidation in healthcare is such a problem. We had the CBO here before us, and before this committee, before the Energy and Commerce Committee. We had the director of the CBO, the Congressional Budget Office, as well as about 20 of his staff members, and I asked them pointedly the question, give me one example of where consolidation has saved money. Nothing. None of them could give me one example of where consolidation has saved money. Now, look, you've been a member of this august body, and you understand we all want the same thing, regardless of which side of the aisle you're on. We want affordable, accessible, quality health care. And I know that the administration, the Biden administration, has repeatedly said that they want more competition across all industries in America. Given that, can you tell me what HHS's proposed budget does to address healthcare vertical integration and consolidation?
And Congressman, I'll mention that when I was Attorney General, I took on hospital consolidation in California. It is a problem. It's not coordination of care. It's the consolidation which leads to less care that we're concerned about. HHS doesn't have the direct jurisdiction to deal with consolidation as you speak. That's more in the jurisdiction of the Department of Justice and the FCC. But we do try to make sure that care is coordinated, but not in a way that removes competition.
I would submit to you, and I mean this sincerely, I don't know that there's been another agency in the federal government that has failed the American people more than the FTC has in allowing this consolidation to take place. Not only in drug pricing, not only with the insurance companies owning the PBM, owning the pharmacy, with steering, with spread pricing, with everything that's going on in that, and you're aware of it, you know what's going on. There was a study done by the Berkeley Research Group, and granted it's a little bit aged now, but it was last year in March of 2022, that showed that only 33% of the price of a drug goes to the pharmaceutical manufacturer, which begs the question, where does the other 67% go? It goes to the PBM, to the middleman. We have got to address that. It's so clear and such an abuse. And we see the egregious practices that are taking place with the PBMs. I've got a bill now, the Help Copays Act, where they are not allowing a credit from a manufacturer to go toward their deductible. They do not allow that. It's just awful. Let me switch gears for just a second. In October of 2022, on a social media post after swearing in the new director at the National Cancer Institute, you tweeted, "Cancer knows no bounds, and neither should our efforts to prevent cancer deaths. Together, we'll advance Cancer Moonshot." As you know, in the IRA, there was a part in there that dealt with drug pricing. And you're well aware of that, and I'm sure trying to implement it and administer it now. The CBO has said that that's going to result in 15 fewer cures in the next 30 years. How can you say that we're going to advance Cancer Moonshot when we're eliminating potentially 15 cures in the next 30 years? A cure that could be the cure for Alzheimer's.
Congressman, I actually disagree with that. I think you're going to see more than 15 new cures come on the market over the next several years as a result of the legislation that we have passed.
Then why did CBO say that? I didn't say it. CBO said it.
That's a question you'll have to ask CBO.
So you disagree with that?
I disagree.
Unbelievable. Thank you, Mr. Secretary, for being here.
Thank you.
Gentleman's time has expired. The chair now recognizes Mr. Crenshaw for 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. I want to follow up on that because it bugs me. I thought it was actually 30 drugs that the CBO estimated would not exist, and plenty of other estimates have much, much higher. We've talked to industry, we've already seen the dollars drying up from investing in what they would call higher risk investments. That would definitely be Alzheimer's. So what drug companies are going to do because of this price cap rule, what they're going to do is they're going to invest in quote unquote safer investments. So the drug companies will be fine. They'll be fine. You know who won't be fine? Alzheimer's patients who want that cutting edge drug. That is a fact. And you guys can sit there comfortably in your position on this because you know that we can never prove a counterfactual because there's another element of history that we will never know about. And it's very, very frustrating. But I want to talk about your budget. So one thing that concerns me, and the chairman mentioned it, is the president's budget mentions climate change 42 times, mentions fentanyl twice. What's the leading cause of death for adults age 18 to 45?
Congressman, I would mention that while we may have mentioned the word fentanyl, we put $10.9 billion more than I think any administration has to fight overdose.
I appreciate that. I'm not sure what that money's going towards, but
we can outline.
It's opioid. I mean, the answer to my question, you didn't answer my question, but it's opioids. I'll just answer it for you. It's opioid overdose, right? Most of that is fentanyl. There's about 100,000 people or more to opioid overdose. Almost 80,000 of that's fentanyl directly related. You can't even compare that kind of number to climate change. Not even close. I mean, if we want to actually compare, let me ask you actually, I mean, is HHS in charge of regulating carbon emissions? Am I missing something here? Why do you guys have an Office of Climate Change and Health Equity funded in this budget?
Congressman, I think it's a proven fact that the impacts of climate change are affecting the health of Americans and people around the world.
How have you quantified that?
Excuse me?
How have you quantified that?
I can get you some of the research that's been done. I can show you some of the communities that have been affected. We can do any number of ways to quantify it. You can let me know.
I have a way of quantifying it. Here, I'll help you out. So in the since 1900, deaths due to nature have plummeted by over 90%. Actually plummeted over 70% just since Biden took office. So weather accounts for somewhere around 0.07% of worldwide deaths, 0.01% in the United States. And that's by the way, with the population increasing like tenfold. So there's a completely negative correlation there, and we're pretending like it's a crisis, and we're scaring people to death about it. And you're telling hospitals that they should be going to net zero. Of all of the locations in America that I would want to have reliable energy sources because people are on life support, I think hospitals would be one of them, right? And if hospitals go to net zero emissions, what kind of effect is that going to have on our temperature in 100 years?
Hospitals, one of the major, the healthcare sector is one of the major contributors to pollution in the world.
What? How do you quantify that?
We can get you the information that shows that the healthcare sector, because of its production of lots of different and uses of lots of different chemicals, the fact that it's a very widespread industry, it does have a major impact on the climate.
So you're just getting rid of these chemicals. Why don't we get rid of plastics too? The plastics that are used for medical devices that save people's lives. Is that a good idea?
I think most people would say to you that where there is a use for plastics, but we don't have to have so much plastic in the world that it's causing major degradation of our environment.
What you're saying is terrifying. What you're saying will harm people. I mean, high-quality plastics are used in an extraordinary way for cutting-edge medical devices. They're used in everything in a hospital. And what percentage do you think our healthcare sector contributes to overall carbon emissions? You said it was significant. You said it's one of the most significant. So what's the percentage? Do you have a ballpark?
Of the industry of the sector?
Yeah, you just said the healthcare industry is one of the biggest contributors to carbon emissions. So do you have a ballpark percentage of what that might be?
I don't have it in front of me, but I can get you that information.
I think it's probably less than a percentage point. I mean, I see these numbers all the time, especially on this committee. Transportation's a big one, right? Power production's a big one. The healthcare sector is a big one. That's what you're saying?
The healthcare sector is a big one.
How much money are you guys wanting to spend on this in your budget?
Spend on what?
On this office?
It's a small fraction of the entire budget.
Uh-huh.
I can tell you the exact amount if you give me time to look through the book.
I only have 7 seconds, but thank you. I yield back.
The gentleman yields back, seeing no one on the Democrat side. The chair recognizes Dr. Dunn for 5 minutes for questions.
Thank you very much, Mr. Chairman. Many sectors of our healthcare industry today are frankly in crisis. Last year, the Democrats passed the inflationary spending policies that are squeezing American families to their limit today. They're facing tough decisions on whether they buy food, gas, or medicine. Artificially subsidizing the Affordable Care Act marketplace at the expense of the taxpayers and forcing price fixing on our innovators are two examples of top-down government policies that distort the market and fails the American people. This next year, White House Fiscal Year 24 HHS budget calls for continued propping up of the ACA and makes no mention of expanding health savings accounts or alternative insurance frameworks that would actually meet individual needs. So that leaves the ACA as often the only choice for consumers. I think similarly, these top-down price controls mean that the government bureaucrats will choose which medicine patients will have access to. So this is taking choices away rather than giving choices to patients. Mr. Secretary, under the IRA, small molecule drugs will be the first subject to price negotiations after 9 years, while biologics at 13 years. Economic analysis of this has suggested, and we've talked to the pharmaceutical companies, that this will eviscerate investment in small molecule drugs. Can you look into the crystal ball of the future and tell us which diseases and which patients are not going to get their medicines because of this?
Congressman, thank you for the question. And while I won't use a crystal ball, what I will tell you is that Americans are going to save a lot of money by having to pay lower prices for the prescriptions that they need.
I think they're just not going to have the medicines to take. That would be my opinion. But so of the 90 new therapeutics approved just since 2020, 26 of those were for cancer, and all of those were primarily small molecules. All right, so therefore, innovation in the cancer space is going to be hit hard in the future. That's a prediction that our economic analysis and the pharmaceutical industry has been making loudly. Keeping with the theme of drug development, Mr. Secretary, another concern is that we are not producing the drugs that we need, the drugs we use daily, whether at home or in doctor's office or hospital, here in America. For more than a decade, China has been the largest producer of APIs in the world. And I won't go into the statistics of it, but even before the pandemic, in 2019, the Department of Defense acknowledged in testimony before the U.S.-China Economic and Security Review Commission the national security risk of Chinese dominance of global API markets. Mr. Secretary, given how important domestic drug manufacturing is to ASPR's national health security strategy, what is the department doing to incentivize domestic supply and production of API and API substrates as well?
Congressman, thank you for the question. I think this is one of those issues where there's bipartisan support. We are trying to increase the domestic production. We are trying to make sure supply chains aren't disrupted. We make some investments in the budget to make sure that there is the capacity for us to incent the production of a lot of the kinds of things that we saw during COVID, basic things from masks to also having the materials for vaccines, have that material made available through the U.S. domestic manufacturing sector, and we're hoping that we'll get the support to do that with Congress.
Well, so I certainly hope that I want you to ask you to go back and take a look at the FDA's approval process of manufacturing as well, because it gets bogged down. Even if you have a plant and you can't use the plant, that's a problem that our industry is facing now. What is HHS doing to prepare us against future pandemics, epidemics, biologic attacks?
We continue through NIH to do the research on the next generation of vaccines and treatments. We continue to see CDC reach out to our state partners to make sure that we can collect the information that not only lets us detect and surveil, but also to spread the information on best practices. We continue to have ASPR working to deal with COVID as it stands today, our Preparedness and Response Agency. They are the ones that are still tracking what goes on with COVID. And
We're running out of time, Mr. Secretary, but I want to make a comment. I want to add to it. Actually was a doctor in the Army, worked at the Chemical Biological Warfare Headquarters up in Fort Detrick, and know something about surveillance of these organisms across the law. We did not do a lot of the things that we can do, that we know how to do, that we're actually pretty good at in terms of surveillance, diagnostics. And again, I want to say the small molecule therapeutics, which are really, really critical. We can't just depend on vaccines. That's way too one track, one-minded. So with that, I see my time has expired, and I will yield back, Mr. Chairman.
Thank you. The gentleman yields back. Chair recognizes Dr. Joyce for 5 minutes.
Thank you for yielding, Mr. Chairman. And Mr. Secretary, I would like to turn to the Orphan Drug Act and its impact on patients. Rare disease and cancer patients have benefited from the development of over 600 new treatments since its enactment. Despite these advancements, there are still too many patients living with rare diseases and cancers that still have no treatments available to them. Unfortunately, Democrats' so-called Inflation Reduction Act threatens the continued success of the Orphan Drug Act. Specifically, it does not protect therapies that treat 2 or more orphan diseases from the law's price-setting scheme. As a result, we already know of 2 companies that have cited the IRA as a reason not to continue rare disease drug development. As a physician, I believe that we must do more, not impede the pipeline of new life-altering therapies for patients living with rare diseases and cancers. Secretary Becerra, can you please expand on the commitment from yesterday's hearing at Ways and Means on how you will specifically utilize the guidance and the rulemaking process under the IRA to ensure that these patients aren't robbed of the future of cures?
Congressman, thank you for the question, and absolutely, that is the goal, to make sure that we're putting as many innovative and curative medicines out there for Americans to be able to buy. The difficulty is they're not able to afford so many of those medicines. And so this law would do nothing to impede the innovation, the research. What it would simply say is, once you've got a drug out there, make sure you're charging a fair price. And a fair price would mean
But the
you get to
pharmaceutical
make a profit
companies
off
have
of
already stopped.
your invention.
They've already announced to us that they're going to decrease their ability to do that research and development into new life-saving medicines.
Why would they say they're going to decrease their investment?
I think my questions will reveal that answer. The guidance process for the IRA that you designed greatly discourages input from patients and physicians.
And how does it
You
do
gave
that?
them hardly any time to submit no clear direction on treatment alternatives and outcomes that you're interested in, and then won't tell them how, if at all, you considered their input until months after a final decision has made. Will you commit today to use the input that you get from patients and from doctors?
Oh, absolutely. But Congressman, you've misinterpreted the law. We don't tell any company what they can and cannot do. We simply say, when it comes time to put it on market, let's make sure you're charging a fair price. Let's negotiate for a fair
But under
price.
your guidance, what is the earliest that individuals, physicians, patients will hear from you on how you use their input? And would you consider additional steps to engage with them during the process?
We will begin the process this year, where we will announce which are going to be the first 10 drugs that will be negotiated. We will go through a very public and transparent process, and we hope the pharmaceutical industry will join us in trying to make that transparent.
And what about
for the public.
patients? What about patients? What about physicians?
That's what the public. Patients are the public, and we want them
And
to
what
have access.
timeline will your response be when they submit their concerns to you? Will
That will be ongoing.
An outline process that they will receive that before the final decision is made?
The public.
Thank you. I
participation will be ongoing.
appreciate that commitment.
But Congressman, I don't understand how we're stopping a company from making investments. All we're saying is, once you've created that drug, let's negotiate to get the best price for Americans.
Well, I think there's a case in point right in front of us and sitting right behind you today. While testifying last week about CMS' decision to limit coverage of new Alzheimer's disease therapies to clinical studies, you made a distinction between the FDA's process and CMS review process. You responded, quote, CMS has to remain consistent in the way it treats any drugs. How many other times has Medicare refused to cover or impose CED requirements on an FDA-approved drug administered according to its label for medically appropriate use?
Yeah, and Congressman, that approach is misguided because it doesn't take into account the laws that you all put in the books that tell CMS how to operate. CMS is following the laws that Congress passed.
Are there any other medications that have these restrictions? We both know that the answer is zero. There's no other medication. In fact, CMS actions are unprecedented, representing the first time Medicare has refused to cover an FDA-approved therapy administered according to its label for medical appropriate use. And the barriers imposed by the CED mean that people living in rural areas and other medically underserved communities, like my district in Pennsylvania, will face huge restrictions to access. Mr. Secretary, how many national cover determinations have been issued under coverage with evidence development paradigm, which I understand first came into existence in 2005?
Congressman, you've misrepresented what CMS has done. CMS did provide a pathway for coverage. As more evidence comes in, that pathway probably will expand, and recognize that CMS must follow the laws that Congress imposed upon it.
But right now, patients in rural areas who do not have access to tertiary facilities are not eligible to receive this important life-altering medicine.
And Congress, I would suggest that you change the laws that tell CMS how it can operate, because we're implementing the law that Congress passed.
But CMS has not done that with any other approvals.
CMS is following the laws that you all put in the books.
But why restrict one medicine which has such huge impact on so many American patients and citizens, families who care for individuals with Alzheimer's? Why exclude this one specific disease?
It's not excluded. There is a pathway. It could expand.
When I go home to the patients in my community, that pathway has been blocked. I realize my time has expired, and I would ask you to take consideration to allow all patients to have access to FDA-approved drugs. Thank you, Mr. Chairman, and I yield.
Thank you. The gentleman yields back. The chair recognizes Mr. Hand for 5 minutes for questions.
Thank you, Mr. Chair. Good afternoon, Mrs. Secretary. Thank you for being here today. As we navigated the deadliest pandemic of our generation, the U.S. made tremendous progress in our fight against COVID-19. As a founding member of the Congressional Pandemic Preparedness Caucus, and as this committee prepares to reauthorize the Pandemics and All Hazards Preparedness Act this year, it's critically important that we take an all-of-government approach to expand our pandemic preparedness efforts. We must look at our response systems through fresh eyes and get creative on how we protect the health of the nation moving forward. For example, in response to 9/11, Congress established ASPR, stood up BARDA, and required the development of a national health security strategy. As we come out on the other side of COVID, we must again apply the lessons of a costly crisis by updating our preparedness and response structures and recalculating the resources necessary to robustly fund our pandemic preparedness efforts. HHS has relied heavily on industry to develop medical countermeasures. These public-private partnerships saved millions of lives through vaccine development when HHS, with essential support from the Department of Defense, launched Operation Warp Speed. However, I am concerned that HHS doesn't have the capacity to achieve similar success in the future with current budget constraints. Unless appropriately resourced, ASPR can only go so far to support the development and manufacturing at scale for future vaccines and therapeutics against unknown viral threats that can lead to a devastating pandemic. While taking a look at HHS's budget justification for FY24, I'm curious to hear why the administration generally included funding to address longstanding established threats in their discretionary request, but concentrated funding to address emerging unknown threats in the mandatory request. So, Mr. Secretary, if we are unable to fund these mandatory components this Congress, is it fair to say that we will remain vulnerable against unknown viral threats like we saw with COVID?
Without the preparation, without the resources to prepare, without the resources to employ the best practices that we know, we are vulnerable to further attacks from disease, for other ways that could cost the life of many Americans.
Thank you. In December 2022, the Department of Defense issued a new approach for research, development, and acquisition of medical countermeasures and test products, which moves away from MCM acquisition focused on a set list of known threats. The revised strategy pivots toward a new emphasis on broad-spectrum MCMs as a first wave of protection against novel and emerging threats, paired with capabilities to rapidly develop a second wave of narrow-spectrum MCM once the threats are identified and characterized. Is HHS thinking about the threat to the public at large in a similar manner? And if so, does the budget request provide sufficient funding to provide broad-spectrum MCMs to achieve this flexibility capacity?
We have a request that would let us address the public health threats that are coming before us. It is not all we need. We will need more over the years, but this at least allows us to continue the work that NIH, ASPR, our unified effort across the government are working on to try to have that preparation in place. We would love to see more domestic preparation done, so we're ready to deal with it here domestically if we need a particular material or medicine. We are trying to make sure that we're prepared with a stockpile, a strategic national stockpile that can address needs. We want to make sure that we are prepared for any supply chain issues that could result if we have international disruption. And so the monies that you see in our budget are geared towards making sure we continue the work that's being done, but long term, it's going to take much more than that.
Thank you. I think I have time to switch gears for one other question, because you're probably aware that last Congress I authored the Biopreparedness Workforce Pilot Program, and it's a new loan repayment program at HRSA aimed at incentivizing individuals to enter infectious disease healthcare professions in underserved areas. I'm pleased that the pilot was enacted last year as part of the omnibus, and that the President's budget request included an increase in funding for HRSA to support the health workforce. Mr. Secretary, do you believe we need a strong infectious diseases workforce to improve the nation's pandemic preparedness? And will you work with us to fund and implement the Biopreparedness Workforce Pilot Program in order to boost recruitment into infectious disease careers in underserved communities?
Absolutely agree. Thank you for your leadership on this, and we look forward to your success in providing the resources.
Thank you. Thank you. I yield back.
The gentlelady yields back. The committee has a bill on the floor. I understand there's one member rushing back, if that's okay, because we're a little ahead of time, if that's
perfectly
okay with you.
fine.
Doctor, so we got a physician coming back and if she's here in a minute or so, we won't hold you up if not. But so while we're doing that, I have documents submitted for the record. There's been a list distributed amongst the majority for documents we, both sides of the aisle, want to submit for the record, and without objection, so ordered. Thank you. I mean, let me see if she's within 30 seconds. If so, we'll stay. I appreciate the opportunity. Appreciate you doing that. As you know, when you're at the end of the line, you got a time when you've been there before, right?
I've been there, Mr. Chairman.
Well, thank you. I appreciate the offer. And while we're waiting, I'm not taking more time from work unless you want time as well. There's some opportunities for us really to work together, particularly on price transparency. And I think that we're going to do that. There was an excellent hearing yesterday, I think, from both sides of the aisle, and we really want to get to the healthcare costs and get to the bottom. And so I'll give you some time too, since I'm taking it. But
Well, thank you, Mr. Chairman. I didn't expect to have additional time, but I will. I will take it, and really just say thank you again for all of your work and focus on improving the health outcomes for the American people. And I now am going to give 1 second for the gentlewoman to get herself seated and situated. And doctor to doctor, I will turn it back over to the chairman.
I'll turn it back. And just a point of personal privilege, we have some guests who you see in the room with us today and concerned about the CMS rule. And I could comment on, but that gets into a new set of questions, so I'm not going to do that. But if Congress has something in the law that's preventing you from moving forward with that, which I'm not sure that's actually the case. I mean, understand that the process is set up, but if we need to improve something, let us know and we'll.
The standards are different, and that's what I think people don't recognize, that FDA and CMS operate under different standards, and we have to follow that guidance that we have in the law. Congress could change that, but we have to follow those different standards for the different agencies.
Well, I appreciate it. I want to get into more questions with that. So I'm going to yield to Dr. Miller-Meeks, and that'll be our last question. for the set of questions. Dr. Miller-Meeks, you have 5 minutes.
Thank you, Mr. Chair, and Secretary Becerra, thank you for testifying before the committee today. HHS's budget summary document asks for a $5.2 billion increase in healthcare fraud and abuse control program funding, specifically listing cutting-edge data analytics to detect trends and outliers. In a Senate Finance Committee hearing, you mentioned that the President's FY 2024 budget request bolsters HHS's healthcare fraud and abuse detection and enforcement work. Furthermore, HHS's OIG, Christy Grimm, stated in her confirmation hearing that she is committed to expanding HHS OIG's use of sophisticated data analytics, including leveraging artificial intelligence and machine learning to proactively monitor and address fraud, waste, and abuse in the HHS programs. Both in the Healthy Future Task Force for the Republicans, as chair of the Modernization Committee, I talked a great deal about artificial intelligence and its use in detecting waste, fraud, and abuse in the Medicare system. I'm currently drafting legislation that would require Medicare to use advanced algorithmic technologies such as artificial intelligence, machine learning, and predictive modeling to combat fraud, waste, and abuse in the fee-for-service program. Estimates of healthcare fraud range from $50 billion to $300 billion annually, and unfortunately, OMB and GAO have identified Medicare as an at-risk for improper payments. According to a 2015 OIG report, every dollar invested in AI fraud detection yields $5 of savings, highlighting the need to invest in this technology. I support the use of AI in improving program integrity, but want to ensure that AI technology is not misused to deny legitimate patient claims. Mr. Secretary, how can we apply lessons and AI innovations from the commercial and Medicare Advantage space to root out fraud, waste, and abuse in Medicare fee-for-service? And will you commit to working with me to responsibly strengthen HHS's fraud reduction capabilities?
Congresswoman, we would absolutely look forward to working with you because everyone is still trying to figure out how we can make the best use of AI and make, as you said, use it for the right purpose where we can probe, but not for the wrong purposes where we might exclude people from care. So very much would look forward to working with you because we know there's a lot of fraud that's going on within the Medicare system.
Yes, as a provider, there is fraud within all of our systems, and we don't want to deny legitimate patient claims. We want them done in a timely fashion, and we don't want to delay provider reimbursement. Let me also echo the sentiments of other individuals and other representatives in this chamber this morning. I took care of my mother with Alzheimer's the last 2 years of her life, and I would say that for CMS to deny coverage of a medication that has been shown and approved by the FDA that could benefit those with Alzheimer's, I think we can, you said that we don't want to cut spending in Medicare because we want to provide people access to care. And I would say we can ration care, and it's another name for cutting spending. I also want to, as a physician, express my displeasure at CMS's rule on surprise billing. We were very specific in the law. I was not one of those members of Congress, but followed that very closely, was very supportive of the legislation that was passed, and it was done in such a way to make sure that the rulemaking process followed what we were passing in legislation. As a provider, as a doctor, we feel that the comments we've had back from HHS and CMS have been less than satisfactory, and I would strongly recommend and encourage you to revisit the rule on surprise billing and make sure we're protecting providers and patients. Thank you very much. I yield back.
Thank the gentlelady for yielding back. And Mr. Secretary, that concludes all members' questions. We really appreciate your time and your effort to be through here. I know you've seen it from both sides, and hopefully you've had a nice morning. We appreciate it very much and appreciate you being here. And like I said, look for the opportunity to work together. I remind members they have 10 business days to submit questions for the record, and I ask the witness to respond to our questions promptly. There were several times when you said we'd get back. We don't want to be here next year going, you said last year you'd get back with us, so we appreciate just prompt response for that, and I know you'll do that, and we appreciate it. And members should submit their questions by the close of business on April the 12th. And without objection, the subcommittee is adjourned. Thank you. Thank you.